Hello, everyone. It's a great pleasure to welcome you all for the second international workshop. Next slide, Siva. Second international workshop on AI or infrared images for medical application, what we friendly call as AIIMA. We started AIIMA 2022 last year, and as you know, it is co-located with one of the largest medical imaging conferences, MICCAI 2023 this year, which is being held in Vancouver. As you know, this is a hybrid event. We are going to have this virtual. We are so thankful to have all of you be part of this event. We have received several papers from all over the world, including Europe, India, of course, Turkey, Brazil, and very many places. Can you hear me okay, Siva?
Yeah, Geetha, we can hear you.
So we have a great lineup today. We have a great lineup of different activities, and we have 4 sessions. The first one will be an opening session, which will be featuring 2 important introductory keynotes, I would say. The first keynote is basically by none other than one of the key organizers, Teja. who is going to take us through a quick introduction to thermal imaging, but with a very different perspective, which is more data science-oriented perspective. We know that MICCAI is most well attended by image processing experts, data science experts, and like. And so we want to give them a different kind of a computational introduction to thermal imaging, so that we can get more and more researchers to come on board to do computational analysis of thermal imaging. Thermal imaging, as you are all aware, is actually a new imaging modality that is coming into the medical field. Of course, it's in one way old, in the sense like in 1974 itself, there were several papers which talked about utility of thermal imaging for medical applications. Having said that, while there are several thermographers who are using it in their private practices and so on, it's still not in the main line of medical practice. And in order to do that, we believe adding computational analysis on it will make it more objective and repeatable and scalable, and also accurate enough to be used for clinical practice. And you'll see more and more of that the rest of the day, why we think so and where is it today. So in the first session, we are going to talk about an introductory view of thermal imaging for data scientists, inviting more and more researchers to come on board to start analyzing thermal images from a computer scientist standpoint. In the same session, I have the privilege of interviewing 3 top radiologists and oncologists who are using thermal imaging for their practice. And they have only adopted it after it became an AI-enabled solution. So I'm going to talk to a top oncologist from Philippines, Dr. Norman Augustin, a very, very senior radiologist from India, Ramprakash sir, as well as Dr. Sudhakar, who is a very well-known radiologist, specialized in breast imaging in a top hospital as well. So I'm going to talk to them and ask them what they feel about use of infrared imaging, and particularly when AI is combined with it. In the second session, we're going to actually go into more detailed research, upcoming new techniques in thermal imaging using top AI algorithms. For example, how do we do the 3D convolutional neural networks, from Brazil? And we also have, different kind of breast imaging algorithms, which will be shared in the second session. And Professor Brioschi is also going to talk about socioeconomic impact of AI in medical thermography. This session number 3 is going to look at AI for non-breast applications, because, of course, breast imaging and breast thermal imaging has been the most top application that is mostly used, but there are also several skeletal-muscular applications, applications for thyroid, applications for diabetic foot, and so on, which we will cover more from a research standpoint in session 3, the upcoming research, emerging technologies in these areas. The session 4 would be led by Professor Alex, who is going to bring up a data challenge. How do we do 3D modeling of thermal images, and can we actually pick the brains of several of the MICCAI data scientists to actually make this really feasible? So here again, we do have 2 very upcoming research papers in 3D modeling of thermal images. And Professor Alex is also going to talk about a data challenge and ideas that we can use for next year, so that more number of people can even come on board and start, developing newer software and intelligent applications using thermal imaging and make the world much more happier. Finally, we conclude with an excellent panel again from practitioners, for people who have built it, who have taken the innovation to the market much before everyone else, making it real product, making it really feasible on the ground for doctors to use it. So Himanshu is going to talk to 4 top startup CEOs, and then we conclude by thanking all of them who made this happen. So I'm very, very excited to hear what all our researchers are going to talk about, what our doctors and scientists are going to talk about. Raise up with me to first get introduced to thermal imaging with a new perspective, a perspective which is coming in from a data scientist. And I give the stage to Siva for on the next part. Thank you. Enjoy.
Hello, everyone. Welcome to AIIMA 2023. Hope you can see my screen. Ronak, can you confirm?
Yes.
Okay. So today I'll be talking about giving an overview about thermal imaging, but in a data science perspective. The agenda of this talk is as follows. First, I will cover basics of thermal imaging, followed by manual interpretation challenges. Then I will talk about some AIIMA clinical use cases and some of the open source data sets that we can leverage, and then what it takes for deploying this solution in clinical practice. What is thermal imaging? It is nothing but measure of surface temperature distribution. Every body emits long-wave infrared radiation. What thermal cameras do is that they convert these long-wave infrared radiation into temperature values. What we are seeing is a thermal image of a breast region, and each pixel here represents the temperature value. Since the temperature values are crux for the interpretation, let's understand how these temperature values are really obtained. So let's say if you want to get temperature distribution of a target object, what infrared thermal camera receives is three different emissions. One directly from the target object, other the emission that is reflected, that is generated by heat sources, surrounding heat sources, but is reflected by the target object. And third one is atmospheric emission itself. Infrared thermal cameras internally use some parameters to construct the temperature of the target object by assuming some parameters. So let's go into details of these parameters, because it is important that we set these values to their true values. Otherwise, what the temperature values we might see might be deviating from what the actual temperature values are. The first one is emissivity. Emissivity of an object is defined as its capability to radiate thermal infrared radiation compared to a black body at the same temperature. Emissivity value of 0 indicates a perfect reflector, whereas emissivity of 1 indicates that it's complete absorber like black body. Most thermal cameras, if you see, it comes with a default value of emissivity of 0.9 or 0.95. So it's important that since we are talking about medical thermography, we have to set this value to 0.98, which corresponds to the human skin surface. And depending on the racial features also, this value can be varied from 0.95 to 0.98. There's interesting papers on what emissivity value we can set for different humans. The second important parameter is reflected temperature, which corresponds to the amount of thermal infrared radiation emitted from background or surrounding objects, but is reflected of the measuring object. That is why it is important to ensure that there are no strong heat sources or reflective surfaces near the imaging area. If you ensure that, you can assume this value to the environmental temperature such as 20 to 24 degrees centigrade. The third parameter is atmospheric transmissivity, which is the ability to transmit the thermal infrared radiation. It depends on the relative humidity in the imaging area and also distance between the camera and the measuring object. But for most of the practical medical thermography scenarios, this value would be very close to 1. The next parameter is atmospheric temperature, which is nothing but the ambient temperature. This you can get it using standard room thermometers. But since atmospheric transmissivity is tending to 1, this parameter has minimal influence. Fifth parameter is Boltzmann constant, which is a constant value. So let's see a demo how these values could really impact the temperature values of what we are measuring. So this is a thermal image, and we are tracking the pixel temperature at this point. So this is captured with the default camera settings, which has emissivity of 0.95. If I change this value to 0.98, you can see that the temperature dropped by 0.2 degrees centigrade. And this is not like a uniform temperature. It depends on the pixel also. And if we change the reflective temperature, we again saw a dip in the temperature. Whereas when we adjusted atmospheric temperature or relative humidity or the distance, it didn't impact that much. Whereas these values also might get influenced depending on the temperature values, what we see. What thermal cameras are giving us is raw temperature values. So for human interpretation, we require them to convert into thermal images. For this purpose, we use color bars and we transform these temperature maps into thermal images. So these are the four commonly used color palettes for converting into temperature images. Rainbow color palette is very predominantly used because it can highlight the abnormal region properly. So what happens is any temperature is less than 20.9 in this scenario is assigned to blue or dark blue. And anything above white is assigned, anything above 31.8 is assigned to white. And grayscale, animated grayscale, both are used specifically for analyzing the vascular changes because we can see the vascular structures in these color palettes well. Iron hot color palette is a general thermal imaging palette, but it is used very minimally in medical thermography. But this is also another standard color palette which we typically see in medical thermography. So when we convert these temperature values into thermal images, there is an important parameter that which can change the interpretation significantly. It is temperature limits. So what you are seeing here, both are obtained from the same temperature matrix, but with different color bar temperature limits. So the left-hand side is obtained using a rainbow color palette and with a temperature limit of 25 and 39. Whereas same temperature matrix, same color palette. But if we change the temperature limits to 38 and 46, we are seeing a significant heat pattern. And this is biopsy proven malignancy. So that is why manual interpretation requires high expertise and also could be subjective. And not all high thermal patterns can be due to malignancy or any kind of abnormal activities. It could be due to benign condition also. And manual analysis of hundreds of thousands of pixels of different color shades representing temperature values could also be taxing for the manual thermographer. That's where AI can help. So over the last few years, we have seen the applications of AI over infrared images in medical usage in variety of areas. I'll be briefly covering about some of these areas in this talk. AIIMA for breast cancer. It is one of the predominant use case which we see. The high metabolic activity required for cancerous growth is fueled by increase in blood supply, which increases the heat pattern of the tumor region as well as the surrounding region. The latest infrared thermal cameras can capture minute temperature variations up to 0.05 degrees centigrade. And with the help of AIIMA, that is the use of AI over infrared images, we can differentiate whether it is a normal or a malignant heat pattern. If you want to start working in this area, there is this open source dataset called breast thermal imaging dataset from Visual Lab, where you can see the breast images in their standard views as well as the time series data. Using this, you can work on the problems of breast region of interest segmentation, that is identifying where the breast region in the image itself is a ML problem, and classifying whether the image is malignant or not. And since we have time series data, you can even track the tumor response, tumor heat pattern, and also classify the tumor. And then 3D modeling, which indicates both breast surface reconstruction from the standard views, which we'll be seeing as one of the data challenge in this AIIMA 2023, as well as the internal 3D modeling. Diabetic neuropathies of foot is another area that affects nerves and can lead to loss of sensation, pain, and even ulcers or infections. Again, these can cause changes in heat patterns. And with AIIMA, we are able to classify whether it is a diabetic foot complication or not. And there is a data set called plantar thermogram dataset, which has multiple foot images and their corresponding foot complication as well. So you can use this data set for identifying where the region of interest is, localizing where the problem is, as well as classifying whether it is really due to some kind of foot complication or not. Onchocercasis is a very recent development where we found that the use of AIIMA can be used for identifying oncoworms in a non-invasive fashion. High metabolic activity of oncoworms, along with its associated angiogenesis, generates more thermal pattern, and we can analyze these temperature values for identifying whether it's oncoworm or not. And the recent even update also says that we can even classify the fecundity or the density of worms as well. And we have an open source data set for this problem as well, called Onchocercasis Thermal Imaging Dataset from Niramai. So you can use this dataset because this dataset has both RGB and thermal images. And since we're capturing the image from far, and we might be having unwanted region, as you can see here, it is the claws, what we are seeing. So you can use it for region of interest segmentation. You can identify where the onco nodule is, and then classify it as well. Fever screening is an area which has picked up during COVID-19. It has its own advantage because using thermal-based fever screening, we can make it completely privacy aware. And we can do 24-hour surveillance, unlike RGB, where we have illumination constraint. And we have data sets. We have two open source data sets here. One is COVID-19 thermal screening NTIC dataset from Niramai, which has thermal images of people walking into public places and their corresponding facial locations. So you can use that for thermal face detection. And you have a data set corresponding to mask and their corresponding labels. You can use it for mask detection or classification, and finally, body temperature estimation. There is another data set from University of College London, which has open source the data set of thermal images and the thermal phase locations, as well as the respiration rate, because respiration rate is also another parameter which could be an important parameter for fever screening. Head and neck is another area. The vital arteries transmits blood to brain, head, and face, and any kind of condition that lead to vascular changes can be studied with AIIMA. So we have a good open source data set, again from Visual Lab, called Thyroid Thermal Imaging data set. You can use this data set for identifying where the neck region is from the images that we capture, and identifying where the nodules are, segmenting them, and then classifying them, whether it is any kind of thyroid abnormal malignancy or it is a normal one. So the last use case which I would be discussing is related to injuries, musculoskeletal disorders, or wounds. Whenever the muscle tissue is strained or torn, it releases chemicals that result in increased heat pattern. Similarly, deep vein thrombosis and other circulatory disorders of lower extremities can result in variations in heat patterns. And degree of burns, wounds can even be studied with AIIMA. There are not much open source data sets related to injuries or musculoskeletal disorders, but we have this chronic wounds multi-model imaging data set, which consists of both thermal image as well as visual image. And we can use this for identifying where the wound is and identifying where the region of pain, and then classifying it into what kind of wound as well. So this is a slide that talks about if you have a AIIMA clinical use case, what does it take for taking it into clinical practice? The first one is identifying a problem statement with a true clinical need, then assessing whether the clinical use has more benefits over risk by comparing with existing technology. And then the next important step is curating the data. understand whether the data is of high quality or not, understand whether the data is authentic or not, what is the ground truth source for getting the annotations, and check for any kind of potential biases that you might foresee. It could be due to the data source as a bias, imbalance is a bias, or what are the inclusion criteria that are involved while data collection. Once you are confident on the data, the next step is developing AI models. You can use off-the-shelf AI models or custom AI models, but it is important that once you develop, evaluate the models on independent data sets. Explainability and interpretability of AI outputs are very key for clinical integration. So ensure that your models are explainable and interpretable, and keep this in mind from the starting of the model development. Make your models more generalizable as well as reproducible, and understand where the model works and where the model fails. Once you have developed this AI model, the next step for any kind of medical use case is obtaining regulatory clearances and conducting the clinical trial. So both takes a lot of time. So start from the beginning itself, like what clinical trials you have to conduct, and define the clear objectives and the clinical outcomes of the studies, and ensure that the clinical objectives that you are assessing corresponds to the intended usage, what you want to claim. And plan for prospective studies, because prospective studies are lagging in thermal imaging, and they are the studies which increases credibility. And once you get the regulatory clearance, the job is not done. You have to work with doctors and understand how you can make your solution more clinically adaptable. Continuously monitor your model to check for any kind of accuracy changes, and then retrain the model if required. You can either opt for manual retraining, or you can go for active learning strategies as well. There's a very interesting talk by Dr. Squaj, chairman of American Academy of Thermology, which discusses how the medical thermography has been standardized over the years. I highly recommend everyone watch this video on how the standardization has been came across in thermography over the years. Thank you. So in the interest of time, I'll be taking any kind of questions over chat since we have to start the panel discussion. Thank you.
We have 2 minutes. If you have any questions, anybody can ask Siva.
Okay.
Meanwhile, Siva, can you give me a co-host?
Yeah, Geetha, I have another co-host.
Siva, Dr. Ram Prakash here. Can you hear me?
Yes, sir.
Oh, thank you.
So if there are no questions, should we get started? We'll get some 2 more minutes with the doctors. Okay, it's a great pleasure. Okay, so it's a great pleasure to come back to you. And like I mentioned in the beginning, we would really love to talk to medical experts in this field and hear their views about what they think about thermal imaging, how they think thermal imaging with AI adds value to their clinical practice or not, and what do they see as future of thermal imaging with AI as such. Of course, as we discussed earlier and as Siva brilliantly presented, breast, of course, is one of the key applications for, in breast screening particularly is a key application. But of course, there are several other applications of thermal imaging with AI as well. We will hear more about, we'll focus more about the breast imaging application here. And we're talking to three brightest and most senior clinicians, doctors, oncologists, radiologists who are saving so many women from breast cancer. And so it's a pleasure to talk to my mentor and senior radiologist, Dr. Ramprakash sir, my dear friend and extremely reputed oncologist, Dr. Norman Augustin from Philippines, and again, my very good friend and as well as excellent reputed imaging, breast imaging specialist, Dr. Sudhakar sir, on this panel. So welcome, doctors. It's really a pleasure to have you on this second international workshop of AI in infrared imaging for medical applications, which is held co-located with MICCAI. And first, let me start with Dr. Sudhakar. Dr. Can you hear me all? I think.
Yeah, I can hear you.
Yeah, so I think
Hi, Geetha.
Siva,
Hi.
you pin only the panelists. Can you pin all the panelists?
Yeah, I'm doing that. Just give me a minute.
Yeah. So we'll start with Dr. Sudhakar. Dr. Sudhakar, you are an experienced radiologist, breast imaging specialist in a very reputed cancer institute like HCG. You have, decades of experience of just focusing on imaging for breast and early breast cancer detection. You see hundreds of patients every month. What are the imaging tests that you use in your practice, and then how do you see the value of using infrared imaging along with your current imaging tests? Dr. Sudhakar, we'll start with you.
Hi, Dr. Geetha. Hi, panelist. So thank you for giving me an opportunity to share my experience here. So we have tomosynthesis, digital breast tomosynthesis, and we have Siemens Axon S2000 with elastography. And we have a MRI, 3 Tesla MRI we have. And the Thermolytics we started as a clinical trial way back 8 years ago. And it was a wonderful journey because I was interacting more with Siva and Dr. Geetha for a long time. And it was a very good experience. Like initially we started with before actually going to clinical trial, we started with lumps which are a little bigger, maybe a clinically palpable lump. Then we went on to another area where clinicians are not able to feel, even the patient herself was not able to feel. And there are certain clinical scenarios. For example, if a lady has pain in the breast, and sometimes we have it happened like some cases we had done the ultrasound scan, mammogram, we are not able to pick up the site of pain for the lady. So that couple of cases, like especially a fibrocystic disease, if the cysts were bigger, maybe 2-3 millimeters or so, we can pick it up an ultrasound. But again, the mammography, because of density, would lose the information. But thermography can pick up the site of high intense thermal activity, and that would actually correlate with the symptoms of the patients. And that is what one of the I could say it's a functional modality. So even though we don't see it in other images, but on the a patient's perspective of view, especially in terms of pain, it would point out to the area of concern. Not just that, and there are some medications for that. We will supplement it with vitamin E. So after a couple of months, the lady would have disappeared with all the pain component, and on the image also we would see that the hot spot would have disappeared. So that gives us a good indication also, like yeah, it can even go on with the pain component, not just the palpable or non-palpable lump.
Okay.
But coming.
So you were able to use this for some symptoms which are not directly visible in the
Yes.
Mammography and other places. So I'll come back to you,
Yes.
Sudhakar. Thank you so much for that introductory comment. Dr. Ramprakash sir, of course, you are my guru, and contacted you in 2016 itself to see whether there is any merit in using thermal imaging. You have the reputation of being the first person to bring thermal imaging to India. You have taught so many young medical students to become good reputed radiologists as well. Please share your experience with thermal imaging. How was it last decade when you were using it? And what has changed with the AI coming in? What are your perspectives on that, Dr. Ramprakash sir?
Thank you, Dr. Geetha. Can you hear me now?
Yes, sir.
Okay. Now, my journey with breast imaging started way back in 1986, to be very specific.
Yes, sir.
In 1985, one doctor from US, because mammography was very new at that point of time, she came over to India with 6 machines, mammography machines, to popularize the concept of mammography in India. It was so unfortunate that nobody took up the initiative. And in 87, I took up one of her machines and started mammography. That was the first one in Karnataka to start mammography. And unfortunately, it was very difficult to convince our own colleagues and doctors that mammography had arrived in India and it was useful, it's going to be useful. At that time, we did not have the digital technology available. So it was an analog image that we had to create, and it was a hazardous task to create a proper image. And everything depended on the image. Unless we got the right image, it was very difficult to identify any abnormality in the breast. So that's where I started. And I had the best of mammography machines. I had a low-rad machine, which was the best available at that point of time. Then I graduated into mammography and did a lot of mammograms. But 2007 was a turning point in my life when one of my colleagues wanted to introduce me to thermography. And that's when I started, went into US and did a bit of thermal imaging waiting, and then came over and started. And let me tell you, I have given up mammography and I depend totally on thermal imaging today. And it's a wonderful tool, especially for screening processes. It is excellent. It gives all the information that you want. And second important thing is, apart from giving us information about the abnormality in the breast, the treatment profile, whether it's helping the patient, not helping the patient, also can be followed up very well. Then subsequently, you came onto the scene and you took up the data that I had and created AI. Let me tell you, it used to take me about 25 to 30 minutes to analyze one thermogram earlier. Now it takes me 2 minutes to analyze a thermogram image now. Because everything has been documented and you have set up quite a number of parameters by which we can very easily identify the site of abnormality. And I'm happy to announce that we have done a few lakh screenings so far. And I think we have helped, I would think, around 15,000 patients who have been identified with cancers much before any other modality can identify the cancer.
Yes.
That is the advantage we had with AI coming onto the scene. Whereas when I did not have AI, it used to take me a pretty long time and it used to be very slow. It was a rather slow process. And now things have become very fast and speeded up.
And you are using ultrasound along with it.
Yes. That was one great advantage that I had. Yes.
Thank you. Thank you so much for the great opening remarks, sir. Dr. Norman, I mean, you are amazing. You are such a senior, experienced oncologist, 30 plus of years of experience in US. You left your US breast surgeoncy and came down to Philippines to help women, Filipino women. I mean, so much of patriotism out there. I'm really honored to be speaking with you. And of course, you're famous in Philippines to bring new technologies, like MBI and of course now Analytix. And I'm very glad that you reached out to us, when we were all talking about it. Please share your thoughts on how you think innovations in breast cancer and generally, how did you hear about AI in thermology? What are your views about Analytix and your opening remarks, sir?
Well, Geetha, before anything else, I'd like to thank you very much for this opportunity to address this very prominent group that you put together today. And as a matter of responding to your question and inquiry, I'd first like to just give a background of how I got involved in this. And I was faced with a very, very difficult situation where I had to solve the problem. And thank God you were heaven sent, manna from heaven, a gift that I used to give every day. And I just can't thank you enough. And I want to tip my hat off to you and Dr. Siva, Teja, as I was listening to his presentation today. And the reason why I'm just awed with such admiration for you is because several years ago, when this concept about the thermolytics was brought to my desk, and one of my senior fellows here, Leo Santos, came to me and said, I think I came up with a solution to our problem. Before actually the reason is he asked me if I knew anything about thermolytics, or not thermolytics, yeah, thermolytics, but thermography in general. And my initial reaction was, I said, "Oh no, not thermography." And the reason why I reacted the way I did is because, again, you keep talking about senior surgeon and all that. I don't want to think of people as this being in terms of my age, but in terms of experience. And when I was, I grew up, I was born in the Philippines, but I grew up in the United States, and I spent my life there for about 45 years. And part of my journey there was the earlier years when I was doing my training at Long Island Jewish Hospital. This was back in the early 80s and late 70s. Long Island Jewish Hospital had run many branches in New York, and one of them was a little hospital called LaGuardia Hospital. And one of the things that they were experimenting with, that they were toying around with, was the concept about the heat to diagnose breast cancer. We were calling it thermogram at that particular time. And everybody was saying, no, that's a lot of hogwash. This is worthless. And through the years, they did not give up the concept, but what they did was they continued to see if they could perfect it, to improve it. And the problem that they were having was that they were improving this in terms of the thermal gun. And nobody really thought that the problem was not with the image, the problem was with the interpretation of the image. And they brought up all the good, brilliant radiologists in New York and other parts of the United States. And despite the improvement in the imaging, nobody could really give a very accurate diagnosis of what they were looking at. And the problem is very simple, because there's so many shades of gray, so many shades of blue and yellow and black and so forth and so on, that it was impossible for any particular doctor in the world to be able to interpret what this images meant and how they could actually come up with an accurate diagnosis. And so came the biggest genius in the world, you and everybody else in your group, Dr. Siva, right? Siva Teja. And I tell you, you guys are just phenomenal. I can't thank you enough for these wonderful things that you have done. Now, how I got involved in this particular situation here in the Philippines, let me just give you some very, very simple facts, all right? Now, breast cancer is a much ignored disease that's really up to a level of pandemia. It's a pandemic disease that everybody's been looking the other way around and have actually been ignored. No, but the latest COVID came in and left very, very quickly. Breast cancer has been around for years, and now we'll after 2 years, it's almost gone, and will continue. But what breast cancer has been around for many years before this, and will continue on for an indefinite period of time unless we do something about the management and treatment of breast cancer. Now, let me just give you very quickly about some bare facts. All right, there's been a pandemic long unrecognized or ignored by the Philippine government and perhaps even the world long before COVID-19. There are close to 29,000 developed new cases in the Philippines last year, and it's been going on for a number of years now. There are over 5,000 deaths from breast cancer. Many of these deaths occur among mothers, daughters, spouses, often sole breadwinners. As you know, the Philippines has now become a matriarchal society, and our underground economy through the overseas workers is a major source of income for us. Actually, it's up to $35 billion that are supposed to come in. Now, in the instance, 1 out of every 4 women in the Philippines will develop cancer in their lifetime. That means that a quarter of these people who are working now are going to develop breast cancer, and half of them die. And most of those who die without treatment or inadequate treatment. The Philippines has a population of over 110 million. About half of them are women. Over 12 million of them will develop breast cancer in their lifetime. Around 6 million will die from the disease. Over 4 million, as I said, will die with inadequate treatment. And so the problem is huge. The cost of care of 29,000 new breast cancer patients with stage 1 disease per year is around 3 billion pesos. Of this, we're all late stage, unfortunately, in the Philippines.
Yeah, that's I think the main problem.
And the cost of saving lives is about 50 billion pesos versus 3 billion. So you're talking about a savings of 47 billion a year.
Yeah.
7 billion a year. Only if we can detect these cancer cases at a much earlier stage. And so the problem is that the cost of screening is very high. We've come up with all kinds of innovations, all kinds of technologies, new kinds of X-rays, new kinds of chemotherapy, and all kinds of technically advanced management choices. But the basic thing is still there: early diagnosis, treatment.
How do you do it for the whole population?
Yes. But how can we do that? Now, in terms of our local experience here, the cost of mammogram here is anywhere between 4,000 to 8,000 pesos. Now, the cost of thermography is about 75% less.
Yeah.
So that means that the problem about coming up with the money to be able to cover the screening every year is actually been solved by the thermography. Because for every 1 mammogram that we do about 10 thermographies. And then
cost advantage, and I think this is amazing, actually, Doctor, because what you mentioned for Philippines is really also true for India and several other developing countries. So I quickly move on to Dr. Sudhakar. Dr. Sudhakar, what do you think, and where can Thermalytics help in Indian breast cancer care in general? What are your views as a radiologist who's a strong proponent of mammography as well?
Hi, Geetha. So this is like this, especially when it comes as a screening program. I had been to a couple of camps with digital breast mammography. There are a couple of concerns were there. One of them is the number of cases. Okay. So in a mammogram, we can do maybe around 30 or max 35, 40 mammograms in a day. And the interpretation of that would not happen there. It has to come to me in the physical form or in mail or something. So it takes a little longer time. And the another clinical problem is it's based on the technical aspects. Like if you give a more compression, you get a good image. And many of the ladies used to complain mainly about the pain component. In the camp, they line up in a queue, and one lady goes in and say like it's very uncomfortable, it's painful. The moment she comes on next study, is like, really, should I really go for this? Okay, she thinks of it, and that is one component, the pain component, and the other one is the radiation. So some ladies who are educated enough, and they'll be concerned about, should I really go for a mammogram or something. That was one concern. And for us, for an organizers, it's good for us if we screen large number of population. Let's say like 50 or 80, that would cover up for the day. Here, it comes very useful when it comes to Thermalytics. So it is very small device, handheld, mobilized anywhere. It don't require any expert to do a mammogram. Okay, so a good thermographer can, thermography technician can be created in a week. Okay, so you just have to know the cooling time, keep the patient confidence that the privacy will be maintained, and it requires a very small cooling room. And in a camp, what you can do, you can pile up the number of patients with the curtains or something like that, where you can start screening. It may take hardly less than 2 minutes for one patient. And as soon as we obtain the image on the via internet or through the mobile app, we'll get the images. So anyway, the major advantage here it comes is the in terms of triaging of the patients. So who are at critical points? Suppose you have some hot areas. Next, what you do? Okay. So maybe out of 60 or 70 patients, 3 or 4 of them really requires a concern. Like there will be some mass. So when it comes to mass, actually it has a very good advantages over the mammogram is it's not just going to pick up the hot spot. What I have seen is also enhances the feeder vessels. So that gives us one of the concern about the lymphatic spread to the axilla. So what I have done is I just gone through a couple of images and I gone back in the same channel as what the tumor is going up, and I could able to pick up even the lymph nodes as well. So it not just aids in the primary mass, it also helps us in directing towards the concerned lymph nodes. So this is very useful like this.
Yeah, the vascularity analysis. So what does
vascular analysis?
There's more and more imaging analysis that can be done, which can help even the treatment. And yeah, absolutely. Dr. Amprakash sir, I come to you. So basically, can you share some advantages of using thermalytics instead of visual analysis? You did mention about the time and over these years, we have now screened, as you mentioned, more than 1 lakh women. I'm sure you're very happy to see this growth because, initially you had to really struggle to get this to India. How do you think we can scale this more and more? Like, how can we take this to more number of women in India, Dr. Amprakash sir, and how can more women benefit from this, according to you?
There are 2 important things that I would want to think of. One is educating our own doctors, number 1, and number 2, educating the general population, right? So our doctors are very resistant to anything that is very simple, right? So they think mammography or tumor mammogram is the one that is the ultimate, which I think is not correct. Yes. So today, these 2 education processes are very important. Initially when I started with ultrasound and I had the first endovaginal ultrasound, it was so difficult to convince my own colleagues on the utility of endovaginal ultrasound. Today, everybody uses it. Similarly also, thermography is going to be used by everyone. And gone are those days when we thought of doing a biopsy and all that. Because today imaging technology is so good that what Sudhakar spoke about, the lymphatics and all that, can be very precisely identified by imaging technology where you use PET scans. So today the ideal procedure would be to first do a thermal imaging, which gives you a focus where probably the abnormality is, then go in for an ultrasound, which gives you the added information, and a PET scan and a surgery. Once a surgery is completely done, I don't think we need to go in for anything else. This is what I have done for many of my own relatives. And I followed them up. No chemotherapy, no radiation therapy, only good surgery after PET scan and thermal imaging and ultrasound. So this is one thing. Second thing I would think is educating. Education must start from the college level. Lady college levels, we should start educating people on the utility of self-breast examination and going in for thermal imaging once in a year. So these are things that I think we should educate people on. And once we do that, I'm sure we are going to control this disease much like pap smears have controlled cervical cancers.
Yeah.
So
thank you.
Similarly, I think education is very, very important. And educating our doctors is more important than educating the general population.
I think associated with that is also proving the clinical efficacy,
Yes,
making
yes, yes.
sure, absolutely.
People like Sudhakar getting involved itself is a big thing.
Yes,
Big thing in this. Yes.
thank you.
And Dr. Norman also, thank you. So I understand that he is also almost of my age, and he's done a wonderful job, right? I think we should meet sometime, probably physically, to understand each other much better. And the
Sure.
advantage we have with thermal imaging, apart from this, is the progression of the disease. Now, when you thermobiologically classify it, right, in such of those breasts where the receptor factor is high, the progression is also very fast. This is one advantage, great advantage we have with thermal imaging, which we do not have with any other imaging modality.
Absolutely, sir. And definitely, I will invite Dr. Norman to come to India.
Yes, yes,
I
please.
want your comments, Dr. Norman, on what has been your experience of using Thermalytics on Filipino women. You and Leo, like, with your team, you conduct a lot of camps as well. You've been on several TV shows, government panels. What has been the response from Filipino government and people, and how do you think we should scale up in Filipino as well?
Well, the response is has something to do with a comment made by Dr. Brown Trakish, and he's absolutely right. This is such a wonderful equipment and the device that you've developed here. And I think nothing frustrates me more than when people tell me that they've never heard about this equipment before. We've spent a lot of time and a lot of effort educating people. That's the reason why we get involved in some of this news media, television, and so forth. And it's precisely that. They were, for example, this month they were saying, "Can you give us any world-breaking news, some hot news about?" And they don't want us to keep talking about the things that we've talked about. And when we introduced your product here, and you were there at that particular time, we were covered almost for a whole day by the biggest television station here in the Philippines, and yet. The thing that frustrates me and makes me very angry is when people come in here and they see this wonderful device that we have. And it says, how come we never heard about this before? I said, my God, I mean, the exposure and the amount of money equivalent to get this done is so extensive. And you're telling me that to come out and do the same thing, which we've been trying to do before. The thing is, you can't advertise enough. You can't just bring the word enough. You just like when during the COVID, what is the hot news that they were bringing every day? But all they don't talk about treatment and all that. What they're talking about is the new people who have died, the number of deaths they've had, the number of people who are going to die and who have died before. It's the same news, right? It's prevention, and all that. It's not science. The same thing now for early detection and treatment. It's your product that's going to do it. It's affordable. It's good. It's comparable to a mammogram and all the other devices that are around today. And this is the key to survival. So I congratulations to you. And again, this is a very, very important month for us. It's the Breast Cancer Awareness Month, October. And already we've been interviewed. It's going to be published for 3 days. The UN television and now the biggest television station just called me, and we were supposed to be interviewed just this exact minute that we're talking to talk about your product. And I told them they can do this tomorrow or the day after tomorrow instead. But it's a very important news, and they understand this, despite the fact it's come out before. We just have to constantly remind people, right? Don't die from a disease that's 100% curable, and you don't need a fortune. So right now, we've gotten the ear. Would you believe that? You'll be proud of us. We've gotten the ear of the White House here, the president, and we're trying to develop what is called a Women's Empowerment Month. Because nobody takes care of our people. People are dying like flies, all right? And it seems like nobody cares. But we do care. We're going to show them they don't have to have millions of dollars to be able to fulfill the screening. It's a fraction of the cost, but we're already addressing the issue of what do we do after the screening. You have to have diagnosis. You have to have treatment. You have to have after that. And the government is going to help us. They're going to have the money. But thank you so much for your product. I think it's an excellent product. And
I think, sir, this is the first of the bunch of thermal imaging and AI applications that will come up. And this particular workshop and on all the wonderful researchers on this platform are trying to create more and more such tools for solving several other applications, other diseases, and having doctors who are like you, all of you here, who are so open to adopting your innovation, right? There's always resistance. It's very important. It has to be a merger of computer scientists and doctors. And I'm so glad all of you came in. I have one last question to each one of you, separate questions. Dr. Sudhakar, I come back to you. You have been part of several clinical studies where we did comparison of thermolytics with the standard of care. And then, of course, you've been an amazing partner from an innovation and development of the tool itself. So what is your advice to startups and data scientists out here, how they should build the product so that it is clinically acceptable? I remember, when I came to you first in 2016, you said, I don't know about thermal imaging, it may not work, but we can work and then see how it works. And then I'm so glad that you gave us inputs throughout as well. So what is your message to the startups and innovators on this forum? How they should develop the product, AI-based thermal imaging, etc., to make it really usable in clinical?
Hi, Dr. Geetha. So this is like this. Now we should not just focus on the detection part of it, as Dr. Noman said this, and Dr. Ramprakash sir also told about how we have to educate the general population along with the doctors, because many of them still don't believe that it's going to exist. So coming to the clinical practice, what I have witnessed is nowadays many of the cancer patients, they are undergoing neoadjuvant chemotherapy prior to the surgery. So this is all there for the breast conservative surgery, and nobody wants to promote the mastectomy now. Even an old lady would also like to conserve the breast. So in this era, the main concern for us would be not just the T staging. Even the axillary lymph node also is very important. As Dr. Norman said, it's like early detection would be the key that will reduce the mortality. And here, in the clinical perspective, especially for a neoadjuvant chemotherapy for breast conservative surgery, I have seen nowadays the protocol what here in India they follow is the clinical examination. So every cycle they visit the doctor and do a breast examination physically, and then say that it is reducing in size and something like that. Only when he feels that clinically this mass is not reducing, then he will send it to us. So that event would take maybe a couple of cycles. Let's see, like it would take at least 3-4 months before he send it to us. And what I felt is there should not be so much of gap in terms of patient response to the chemotherapy. You should not wait that. So what I was suggesting is let us do a study on the response of the treatment. So that is very good. Even you can go. You can tell the surgeons or the breast oncologist, medical oncologist, in terms of response to the treatment. So we do a longitudinal studies so that we can see the one of the first response would be the decrease in the size. That's what we are seeing. Before decreasing the size, there will be decrease in the desmoplastic reactions. There will be surrounding edema will decrease. So in thermal images, actually, this perilesional edema, that is a desmoplasia or an acute kind of subacute inflammation, is going to come down. So that is a one which will definitely give us, even a layman can also understand looking at the thermal image, the hot spot of the tumor is coming down in size, and also the color is also going down. Even they'll be very convinced about it.
We are actually working on it. It's already ethics committee cleared. So, I mean, that's one application. But I think that you're stressing the point about clinical study is very, very important. Like whatever application, startups take up, they have to go through the clinical study, right? You are saying even for longitudinal study, I think that's a very, very important point. So, Dr. Ramprakash, sir, thank you so much, Dr. Sudhakar. So, Dr. Ramprakash, sir, like I mentioned, you have trained so many breast radiologists, and what will be your message to young breast imaging specialists who are just studying, maybe doing their first or second year surgeoncy? how do you advise, what do you advise them about using thermal imaging for medical application? What clinical pathway you think they should proceed with, and what should they experiment with? Ramprakash sir first.
Thermal imaging is something that is going to stay. So it's something that has been very, very old, right from the time of Hippocrates. So we've been using thermal patterns to identify disease. So this is something that is definitely going to stay. And becoming a part of the imaging spectrum is something that needs to be emphasized a lot more. Not many of my young radiologists are keen on taking up thermal imaging, although now the interest is gradually increasing. But it takes a little more time probably for them to understand the implications of this. Not only in breast is it very useful, it's also useful in many other areas, surface areas like backache. That's another area, sports medicine. That's the third area where it's going to be very useful. So imaging is definitely going to be very much enriched with the introduction of thermal imaging into the imaging field. So that is one thing that all of us must be concerned about. And I think in the near future, thermal imaging is going to be the first imaging process that's going to be used in as far as breast is concerned.
Thank you. Thank you so much, sir. So it's so promising. Dr. Norman, what do you feel? Like, what is your vision for Philippines, and what message do you want to give to India, Philippines, and rest of the Asian countries, particularly the doctor community?
I just want to follow through with the question asked Dr. Prakash, which I think is very, very relevant. Now, let me just give you very quickly the statistics of the Philippines. There are 1,500 radiologists in the whole Philippines to take care of 110 million population. It's one radiologist per 80,000 population. Look at the discrepancy here. More importantly is we personally, I stop suffering the same problem as all over the Philippines. There are just not enough radiologists here to take care of our patients. Screening, again, as we said, is very, very critical in the management of breast cancer. The earlier you screen them, the lower the cost, the lower the diagnosis, and the lower the stage, and the better the outcome. Now, how do we solve this? Let me tell you about our initial 1 or 2 month experience regarding the Thermalytics. We have per device, we have 30 to 40 patients that we can screen every day. The turnaround time and results are sent to the patient within 24 to 36 hours. We have only 3 devices, and have so far screened about 90 patients per day. And so far we've screened about a total of 2,331 patients. The B-score 5 is about 14, B-score 4, 46, consult and diagnosis 18, biopsy 1, surgery. But essentially, this has been quite effective only in terms of efficiency, only in the past 3 to 4 months. I'm sorry, 4 to 6 weeks, all right? It's only about 3 months that we've been doing this, and most of the efficiency has occurred only in the past month. So I think we'll be able to improve this. What we really need very badly right now are the thermal guns. And the more we have, the demands are immense. It's unbelievable. I just saw patients in his office. Now I have senators, congressmen, assemblymen, and even the president is soon going to be coming here demanding the Thermalytics technology. We need to do this, and we need to get it done very, very quickly. But thank you again for your device. I think this needs to be advertised more and implemented as soon as possible. People are dying. It's a serious problem. We need serious solutions.
Absolutely, absolutely, sir. 50% of new breast cancer cases coming in from Asia. That's a big, big alarm. And as you also mentioned, the mortality rates are so high in these parts of the world, 16 to 60% mortality rate, above 50 is most of the Asian countries. So definitely this can. And there have been a couple of questions. I'm not sure how much time we have, maybe like a minute, but the most, common question that is generally asked, can thermal imaging replace a test like mammography, or will it remain an adjunctive test? Maybe we'll keep that question to all the 3 of you. Say yes, no, maybe. Short answer. Can it replace now or later, adjunctive or alone? Dr. Sudhakar.
This is a tough question to answer, because it's the mammography has a lot of publications, and it's been one of the it's there in the national program of many countries. And it takes some more time for us to crack in through this. and bring it to the main stream of comparing, replacing. Now I think we'll just need some more time to, just to compete with the mammogram. And there are certain areas like which definitely has a edge is in the screening mammogram for the rural population in India. So urban population, yeah, they can come down and get a mammogram, but for the rural population, if you can get in and give an awareness and screening, it's going to have a very good model in terms of catering the general public, to try to include into a national program concerning more about the rural population than in the urban population.
Absolutely. Dr. Ramprakash, sir, same question. Will thermal image replace mammogram or remain adjunctive? What do you see?
100%, it is going to replace mammography. Because, when mammography started, we did not have ultrasound. Today we have ultrasound. So ultrasound with thermal imaging is as good or probably better than mammography. And I'm sure your results also indicate that, right? Screening mammogram has got an accuracy of about 80%, 82%. Whereas thermal imaging with ultrasound gives you an accuracy of 92 plus. That is a very, very big jump, right? And that is definitely going to be the mainstay in future, because we did not have all these technologies earlier. So that's why we had to depend on mammography. Today we have PET scans, right? And biopsies are going to be a thing of the past also, because once you have a PET scan, you know where all the disease has spread. That gives you more information than what a biopsy would give you. And your treatment profile also after surgery would be wonderful, because you'll have all the information you want to put the patient on treatment, with what type of treatment, how much of treatment, and all that is going to be determined. So thermography is definitely going to be something new. It's going to replace mammography in a very big way once it is accepted by quite a number of our young doctors.
Thank you. Thank you, sir. So yes, of course, we have done several studies comparing the standard of care. Those of you who want to look at the studies, I saw that some of them have posted it. We will post. There are 33 papers that Niramai has published comparing thermalytics with mammography and ultrasound. Sir, your last word, Dr. Norman. What are your thoughts of, I
came up with that answer. I came up with an answer a very long time ago. But let me tell you, before I even dare answer it, and I even share it with the rest of the panel here, you have to promise me that very soon you have to provide us with those Kevlar bulletproof vests. Kevlar bulletproof vests. Because we're going to get murdered. I'll tell you just a very, very brief story. I just came from the American Society of Breast Surgeons last April. And all my colleagues that I've been seeing every year for the past 21 years, they asked me, Norman, what are you doing now? And I was very excitedly respond by saying, have you heard about this thermalytics? Thermalytics. They look at me like I came from another planet, and they started to laugh and ridicule me. And I said, I'm going to get the last laugh from you guys. And the thing is, everybody's looking back at what it was back in the 80s when this was very fresh and they didn't have this artificial intelligence. And but the truth is, we're very, very cautious here about the warning we see at the very beginning. We don't want to compete with these big companies because they're going to kill the Asian breast center very, very rapidly in no time at all. So I know what the answer is, but I'm not going to reveal it until you send us those Kevlar bulletproof vests to protect ourselves from those big companies that are manufacturing those big machines called mammograms. But thank you so much for this opportunity. Thank you. And such an impressive panel.
Thank you. Thank you so much for your wonderful and candid comments. And just on record, we are not yet replacing mammography. We are still adjunct. We will do a lot more. And like Dr. Sudhakar and several others mentioned, doctors also mentioned for screening and rural areas where there is no mammography possible. Definitely, this is a boon where hand examination can definitely be replaced. And time is not far away where we can, all of us researchers here can create enough evidence to prove to ourselves, to patients and the doctors, that there is a new wave that is coming in, which is AI on thermal imaging, which is not just for breast cancer, probably for several other type of diseases. And that is what we're going to look at in the rest of the session today. Thank you so much, doctors, for being such wonderful expert guidelines given by all of you. And God bless. Thank you. So we move on to the
Thank you.
section 2, where we go into upcoming future emerging research in breast imaging. Over to you. I think this is going to be chaired by none other than another big expert in AI in breast imaging, Dr. Eddie Angie. Over to you, Siva.
Yep. Thank you so much. Can you hear me?
Yes, sir.
Yeah, that's good. I think in the interest of time, we just move ahead. My name is Eddie from Nanyang Technological University, Singapore. Thanks for coming to this session 2, AI in breast thermography. Today we have 3 papers by prominent speakers. First, we have this Professor Marcos and his student, Gabriel. So his topic is in the socioeconomic impact of AI application in diagnostic medical thermology. Very important to the speaker. You have 8-minute presentation plus 2 minutes Q&A, please. Please go ahead in the interest of time. Gabriel, can you share your screen and then just move on? Yeah, great. We can see your share screen. But can't hear you. It looks like can't hear you so far. Have you unmute your mic?
So Gabriel Brioschi,
Yeah. Now can hear you.
when you click on share screen, can you select share sounds option? We're not able to hear the audio.
If you go to the dot.
Can you hear now? Welcome to another exploration of science and technology shaping our world. My name is Gabriel, and we are going to delve into this fascinating scientific article, in which I had the privilege of being part of it. It's titled The Socioeconomic Impact of Artificial Intelligence Applications in Diagnostic Medical Thermography. Let's uncover how artificial intelligence is revolutionizing early disease detection.
Imagine a non-invasive method surpassing traditional diagnostics. AI empowers early disease detection, improving treatments, and cutting healthcare costs. With AI by our side, we're not only diagnosing diseases, but also transforming lives and shaping a healthier, happier future for all. Imagine a world where medical imaging goes beyond our imagination. AI-powered thermography redefines medical diagnostics with advanced algorithms revealing hidden disease patterns, transforming our approach to breast cancer and other diseases. But will AI-powered thermography truly redefine the way we approach medical diagnostics with greater accuracy and efficiency? Yes, thermography, which captures thermal images of the body, and artificial intelligence, which learns from complex data, are coming together to revolutionize diagnostic medicine. Let's explore how this synergy can transform early disease detection. The aim of this study is to address the potential economic impact of implementing AI in thermography for breast cancer diagnosis. There are no studies with precise cost analysis yet. Considering the costs along with ethical implications associated with the implementation of AI technologies in thermography is a crucial step in evaluating their economic impact. This is pivotal for the definitive acceptance and implementation of thermography in public healthcare. A priority for thermography stakeholders, thermology associations, global medical groups, WHO, UN programs, and governments worldwide. This presentation will take us on a thorough analysis of the economic and social benefits of applying artificial intelligence in medical thermography. We will uncover how AI can enhance diagnostic accuracy, increase efficiency, and reduce healthcare costs. There are 5 ways in which AI algorithms can be applied in diagnostic medical thermography. 1. Automated anomaly detection. 2. Quantitative analysis. 3. Decision support systems. 4. Image classification and segmentation. 5. Predictive modeling. AI enables precise thermal image analysis, overcoming human subjectivity, and handling large data volumes in diagnosis. AI in diagnostics can enhance accuracy, efficiency, and cut healthcare costs, benefiting the healthcare system and the economy. Medical thermography measures body temperature using sensors, creating thermal images for non-invasive, radiation-free early medical condition diagnosis. Thermography in healthcare offers advantages: non-contact, radiation-free, non-invasive, safe qualitative and quantitative analysis, high sensitivity, and metabolic function assessment. AI algorithms can help identify subtle patterns in thermal images, enhancing early disease detection, including breast cancer, in unprecedented ways. Breast cancer remains one of the leading causes of death among women. In 2020, WHO estimated 2.3 million breast cancer diagnoses, resulting in around 685,000 deaths. US breast cancer expenses were $200.7 billion in 2020, expected to rise to $222.2 billion in 2025 and $245.6 billion in 2030. Now let's compare thermography and mammography, two diagnostic powerhouses. While mammography has been a standard approach, thermography offers a non-invasive alternative. This table summarizes sensitivity and specificity data from recent mammography and digital infrared thermal imaging studies, highlighting the importance of reliable data in advancing research. In the current landscape of technological advancement and published scientific research, what is already known today about breast thermography and AI is that, first, AI-enhanced thermography and thermal images provide valuable insights into breast tissue vascularity and temperature patterns, potentially linked to early-stage tumor activity. This is a fact. Also, deeper tumors are possible to be detected by breast thermography with or without provocative tests. Second, AI in thermography already exhibits higher specificity and sensitivity compared to traditional methods today. Although it is not a definitive diagnosis, it is highly sensitive. When analyzing studies on mammography, conventional thermography, and AI-powered automated breast thermography, the results seem similar in terms of sensitivity and specificity. On average, mammography has 80% sensitivity and 72% specificity, while conventional thermography shows 89% sensitivity and 56% specificity. AI-powered automated breast thermography has 88% sensitivity and 85% specificity, slightly more accurate. Using artificial intelligence software, our group reached 96% of accuracy with infrared imaging and published the validation in 2016. Our analysis indicates AI-powered thermography's slightly superior accuracy in sensitivity and specificity. The accuracy of detection is evident, which can lead to more precise diagnoses and effective treatments. Third, AI in thermography already detects changes in breast lesions at very early stages, which would be difficult to identify solely with traditional methods. Thermography was shown as the highest risk factor marker for breast cancer. It was found to be a 10 times higher risk maker than family history. Witness their unique capabilities. Thermography surpasses conventional diagnostics with a non-invasive approach, and AI-powered thermography revolutionizes the field, advancing towards a comprehensive and dependable diagnostic paradigm. Potential consequences of this include: 1. This could enable earlier interventions, reducing the need for unnecessary biopsies and total mastectomies, as in this study proposed by Brioschi. 2. In other words, improved detection accuracy can prevent false positives and negatives, minimizing the risk of undertreatment or overtreatment. Promising accuracy improvements aside, treatment decisions rely on multiple factors, demanding comprehensive clinical data analysis, a responsibility ultimately held by the attending physician. AI identifies conservative mastectomy candidates, reduces complex procedures, and preserves a sense of wholeness, fostering confidence and dignity in women's lives through AI thermography. 3. AI in thermography identifies conservative mastectomy candidates by analyzing breast tissue vascularity and temperature patterns, aiding complex breast cancer treatment decisions through comprehensive clinical and radiological data analysis. Thermography isn't the only method. Doctors use thermal data, mammography, ultrasound, biopsies, and genetics for personalized plans. AI adds insights but must consider the patient's full profile. Integrating AI into breast thermography can cut breast cancer expenses by 10%, 20% through early detection and treatments like lumpectomy with radiation, achieving a 98% cure rate over 5 years, particularly beneficiating cases requiring only lumpectomy. AI breast thermography and mammography together identify early tumors with specific characteristics, enabling cost-effective targeted interventions. Current lumpectomy criteria without radiation apply to less than 20%, but may expand to 80 to 90%. Ongoing comprehensive studies validate this, considering clinical scenarios, costs, and AI-guided thermography treatment. Early AI-powered thermography aids timely treatment, cuts costs, and saves lives by identifying conservative mastectomy candidates, minimizing complex procedures. Consider early detection's impact, saving lives, reducing suffering, and cutting unnecessary procedures through AI-powered thermography for conservative mastectomy candidates. To advance thermography, we need more studies focusing on 5 key socioeconomic indicators in these research areas: healthcare costs, system efficiency, clinical outcomes, healthcare access, and overall economic impact. Before comparing thermography versus mammography, consider these aspects in the 5 socioeconomic indicators, emphasizing that accuracy alone should not be the sole focus. AI reduces the biggest healthcare expense, physician costs. It lets them concentrate on clinical decisions, including social, ethical, and local factors, not equipment or infrastructure. AI thermography enhances efficiency, allowing more focus on decision-making, and expanded screening aids earlier diagnoses, complementing mammography. This table illustrates AI's efficiency in automated thermal image analysis, freeing up healthcare professionals for crucial clinical tasks. Furthermore, automated thermography units significantly reduce costs, making them a cost-effective solution for medical imaging facilities. Ethical considerations like privacy, equity, and transparency are crucial in AI's implementation in thermography, ensuring responsible technology use. Prioritize ethical and technical AI algorithm validation in future thermography studies, ensuring independence, transparency, bias mitigation, and community sharing for reliability and impartiality. Ethical validation is an ongoing process. emphasizing transparency and sharing with the scientific community to evaluate algorithm reliability, impartiality, and effectiveness as algorithms evolve. Behind this technological marvel lies the tireless efforts of the World Health Organization and the United Nations. Their dedication to advancing healthcare thermography and promoting equitable access has facilitated responsible implementation. WHO and UN advance healthcare thermography through research, guidelines, advocacy, and empowerment efforts. In conclusion, AI-supported thermography transforms healthcare across fields through research, integration, guidelines, and ongoing evaluation, aiming for a brighter future. As we conclude, let's harness AI-powered thermography for a brighter healthcare future. Thank you for watching.
As we bid farewell, know that the future of healthcare lies within each of us. Let's stay connected, for together we can make a positive impact on the world of healthcare and beyond. Thank you for being a part of this remarkable presentation.
All right, thank you, Gabriel. Maybe we can have one question only, please. Any questions? Open to the floor now. No question, right? I can't see any question online also. No one posts any question. If not, we move on to...
My research revealed a significant fact. Thermography is a game changer, saving money for public healthcare and have a significant socioeconomic impact on facilitating breast cancer screening. The conflict of false positives and false negatives between thermography and mammography is no longer relevant nowadays. With AI thermography, this war don't make sense. Our findings revealed that thermography can reduce breast cancer-related expenses by up to 20% cost reduction, leveraging artificial intelligence. This method enables quick and economic impact assessments, allowing a large number of humans to be evaluated in a single day. Faster, more people, more effectively, and for less money.
I think we're out of time, I think. Yeah.
Gabriel, you finished, right?
A greater number of suspicions cases can be remarkable for mammography to be confirmed, leading to a notable increase in the prevalence of conservative lobotomy surgeries over partial total mastectomies with chemotherapy. This not only streamlines resource allocation, but also gives patients a better option and potentially saves more lives.
Yeah. Thank you, Gabriel.
Thank you.
You finished that presentation? Yeah, thank you, Gabriel. I think in the interest of time, any question? Just one question will do. Because we have two more speakers. If not, thanks a lot, Gabriel, for your comparison of this analysis for early detection using IR. Now we have second speaker by Matheus Baffa from University of São Paulo, Brazil. His title of speak is 3D convolution neural networks for active dynamic breast infrared imaging classification. Yeah, active dynamic is interesting. Matheus, please go ahead.
Hello everyone, can you see me? Can you hear me well?
You can see your slide also.
Okay, great. So it's really nice to meet you all. My name is Matheus Baffa, and today I'm presenting the paper 3D convolutional neural networks for dynamic breast infrared imaging classification. Let me just bring this. Okay. So yeah, this paper was developed by me, Professor Lucas Latari, and Professor Laura Fonsi. So breast cancer is the most common type of cancer among women.
Matheus, you don't mind to put on animation? But it's not in animation mode yet.
Can you see my screen?
Yeah, I can see, but not in animation yet. You haven't showed the slide. You have the slide, but not in animation.
You can click on the slideshow presentation mode, Matheus.
Yeah, correct.
So there's a presentation mode below. You can click on that. Can you share the screen again?
If I click can you see now?
Not yet. Time lag. I think there's time lags.
It says that the screen is loading, so
Yeah, you put it into presentation mode for your PowerPoint slide.
it's already in presentation mode. Oh, you are seeing my screen, right?
Yeah, I can see your screen. Is all other okay with that? With the animation mode?
I think yes, I think it is fine now.
Oh, okay. So is
Siva,
that correct?
you can see the full screen, right?
Yeah, okay, perfect. So let me go back.
Yeah,
And,
yeah. Now it's great. Yeah, wonderful now. Yeah,
yeah,
go
okay,
ahead, please.
perfect.
Matheus, yeah.
So breast cancer is the most common type of cancer among women. And according to the World Health Organization, it is expected annually about around 2.4 million new cases. And there are different screening techniques to be used to detect breast cancer. For example, mammography, MRI, ultrasound. Thermography has shown as a promising, valuable tool to detect breast cancer in the literature. A study from 2016 indicates that the thermography, since the sensitivity of thermography is very close to mammography, and it's a very good type of image. And the demographic images can be acquired using different protocols. For example, there's the static protocol, which acquire only one image per patient. And there's the dynamic protocol, which acquires more than one over a certain time. So the dynamic image consists of a series of images collected over time during a specific period. They are acquired after a cold stress, usually provoked by a fan. And the sequence of image highlights the temperature changes over time. So after the patient is, the region is stressed with cold, the images acquire several temperature over a certain time. And healthy and cancer patients have different heating patterns over this time that you are observing. So the objective of our study is to identify and analyze temperature and trends within the sequence of images obtained through dynamic thermography. First, in our work, we acquire images from the database of mastology research. This database is open and available in the internet. In total, we use 2,980 images, comprising 20 images for each of the 149 patients, all unique, so there's no sequence of 20 images for the same patient. Around these 149 patients, we have 87 diagnosed with breast cancers, and 62 were healthy. And first, we segmented these images using UNet CNN that we developed in a previous work. After that, we stacked these 20 images already segmented over the z-axis, creating a hypercube for each patient. We also developed a data augmentation technique to improve our training. So during the training and task separation step, we used 12 operations to create more variability of our data. These operations are rotation by 5, 10, and 15 degrees in both directions, high brightness, Gaussian smooth. So to make the classification model for this hypercube, we developed a 3D CNN. The 3D CNN received these images and using 9 layers architecture. One is the input layer, which received the hypercube and then passed to the following convolutional layers. So it's 3 convolutional 3D layers, 3 max pooling layers, 1 dense layer, and 1 output layer. The architecture is just like we are seeing now on screen. So the convolutional layers, it extracts 16, 32, and then 64 filter maps, 3D filter maps. It also used the ReLU, rectifier linear unit actuation function. And then in the output layer, we have the healthy cancer. So it's 2 neurons using the softmax activation function. And we combined 4 different strategies to prevent model overfitting. First, we used the 3D spatial dropout, which set our drop rate of 20%. It turns off 20% of the feature maps that was extracted by the convolutional layers. We also use a small architecture, so we use a reduced number of convolutional layers, a reduced number of dense layers, and a reduced number of neurons. We use data augmentation, as explained before, and we also use early stopping mechanism. So we set up to stop training if there's no improvement after 80 epochs. Our experiments, we follow the k-fold cross-validation protocol with k equal to 10, so we have 10 folds. We also hold an experiment using the leave one out cross-validation as well. Each fold iteration, we measure 5 evaluation metrics: accuracy, precision, sensitivity, specificity, and area under the curve. The cross-validation was chosen to ensure that no data leakage among the training the test subsets. And also, since we are modeling the 20 images in one hypercube, we are also dealing with different patients as well in the training and in the testing subset. The results for the experiments, we achieved an overall accuracy of 94% for the experiments with the k-fold, sensitivity of 94% as well. And the leave one out achieved a little higher, 98%. So 3D CNN, that brings out automation and simplification of the process because it's more intuitive and it requires less number of steps when you compare to other approaches that do the same in the literature, which usually converts the 3D data into a 2D format, or extract features, make feature selection, or transform it in time series. The 3D CNN can be benefits for a larger amount of data. For example, by using the leave one out, we observed that with more data, we can get better results. The hypercube model that we developed in this work also is very innovative because it brings the temporal heating process, also the spatial information. So we know where and how it's changing over time, the temperature. And the 3D CNNs are extremely computationally expensive. It requires a large amount of rerun and run to train, although for inference on an application, it requires much less. So as conclusion, breast cancer is a leading type of cancer among women. The 3D CNN has shown to be a very effective in determining patients' diagnosis. The proposed approach has a very good performance, although it can get improved with more data. For future works, we plan on optimizing the networks for lower memory usage and explore alternative deep learning methods. Thank you. These are the references that I used.
Thank you, Matheus.
Does anyone have any question?
Yeah. One question, anyone?
Yeah.
Yeah, Matheus, how you don't mind since nobody asking, how your plan to lower the memory, the local memory?
How I plan to reduce the memory?
Yes, yes. Don't mind just briefly describe it, your future.
Yeah, one idea is to use attention-based methods and also other methods that can reduce the number of features. So if we kind of select which information is being used in the dense layers, we can reduce the dimensionality of the problem. So that's one way we can implement this reduction. And also we can probably try other approaches. We can use the features from the 3D CNNs with other types of AI methods like an SVM or AMLP, something that is more light.
I see.
Okay.
Yeah, I just read out one question from the floor. How does the background of the subject affect accuracy of thermal image? Will uneven temperature of subjects background have any effect? Would you mind to just shed some light on this?
What is the question again?
Is in the chat group. How does the background of the subject affect accuracy of a thermal image?
Oh, okay.
And will uneven temperature of subject background have any effect?
Yeah, so when you are working with the whole image, the background can have a sort of impact during the training because the CNN looks at the entire image. So if the CNNs think that, for example, the neck or the belly is important for determine if breast cancer, the patient has breast cancer or not, it will use this information for classification. So what we do is we apply segmentation to reduce the information, the region of interest just for the breast, so we can exactly know that the CNN is looking only on that part of information, and the rest of the information of the image, the other parts of the body, will not have influence on that. So that's why we used segmentation. Okay, did I answer?
Yeah, I think fair enough. In the interest of time again, thank you, Mr. Matheus.
Okay.
Thank you so much for your nice presentation. Yeah. Now we have a final paper by speaker is Nuba, right? From Fluminense University, Brazil again. The topic is, could the consideration of symmetricity, right, be statistically significant for breast infrared analysis? Yes, we can
Hello,
see.
everyone.
Yeah, please go ahead.
Thanks for having me. I'm humbled by the opportunity. I'd like to thank everyone for your time and thank the session chair, Yi Guiyang. I hope I'm not mangling too much. Your name is. I have this paper to present, which uses the same database that was presented by the previous speaker. So I will have the luxury of diving right into it and probably shave a couple minutes from the presentation, as you have seen it already, the shape of the data we work with. So the idea here in this paper is to explore the idea that because we expect some symmetry in the human body, we try here to quantify that symmetry or the difference between the parts which are symmetric, which can be symmetric in the body, with the idea that not using that is leaving information on the table. So in a sense, that is something we know, that we can expect some symmetry, and here we try to establish how to use that, and that's what we investigate in this paper. Okay, let's jump to the next one. So over the same database that was presented in the previous, that was in the previous presentation, we established 3 levels where we can observe that symmetry. One is when we slice the body into the right and left side of the thorax. We call it that level 2 in this paper. Level 3 is when we segment only the breast area, and level 4 is when we segment each of the quadrants of the breast, and then we flip and compare the features from each part and its corresponding counterpart, symmetrical counterpart. So the internal upper left breast is compared against the internal upper right breast. And the approach we have here for the features is that we study the general global features using hierarchic features for the that segment. And we use a variation of local binary patterns, which are uniform and rotation invariant. That gives us a very good discriminant with a short requirement in terms of the size of the vector that stores at the histogram. And we establish also because of the different nature of each dimension in the hierarchic feature vector, we keep what we call the distance, or the difference between two hierarchic vectors is a simple difference between each of these dimensions. So is a vector subtraction. And when we go to the histogram of the uniform rotation invariant LBP, we propose different measures of distance, and distance here is being used in a loose sense, because we have we consider the histogram as we have different proposals of ways to calculate the distance between the two vectors, and one of them is for example, the Euclidean. Another way is the entropy distance, where we consider one of the histogram as a function, and we try to consider how much information do I need to add in order to describe this other function. So these are the two approaches we have for considering global features and local features. And then for each level, we extract these global and local features, and then then we compare, we build a different set for training and testing, and let's try to go quickly over this thing. In order to compare to consider the question without getting in the merit of which classifier works better with which parameters, we have a pool of classifiers, and then over that levels in these different segmentations, we consider the features, the differences, and then we experiment with adding, given that you have one of the information about the characteristics of those parts, which information about differences give me a better accuracy. So what I'm interested here is not exactly on finding the best classifier with the best hyperparameters, but rather which level of the composition of the problem, either the thorax, the breast, or the quadrants, and which information about the differences can be useful and improve my classification process. And the idea is that once we run this across the entire space of the classifier with the parameters, we're trying to find if some information on the symmetry affect my results across the classifiers. So I'm trying to isolate the effect of choosing the classifier and the parameters, and really stick to the question is the symmetry information that is useful or not. So these are the results we have for. I'm going to go briefly over this, but this is just to show that we picked the metric accuracy, and we varied the parameters for different support vector classifiers in 3 different kernels: the linear, RBF, and polynomial. And we also experimented with the nearest neighbor, more like a baseline, because it is very familiar and easy to discuss and reason about it, and to have a known reference to compare against the others. But this is for level 2, where we're comparing the size of the thorax. This is for level 3, where we have the segments for the breast. And this is for level 4, where we're working with each composition of the quadrants of the breast. And what's important here is not the values in itself, but rather when I have B, which are the local binary pattern information. This is my accuracy when I have the difference between the parts that I'm considering when it comes to their local binary patterns. This is when I have local binary pattern information and I'm adding the difference from the hierarchy features vector. This is when I have the local binary pattern and I'm adding both. So that's the basic idea. I'm always starting with some information about these two parts and adding difference about one or the other or both, which and this is what we found on the variation of the differences between the groups. So what I'm talking here is how much one column is changing with regards to another column where I don't have some information on the differences. So again, just to stress, this is not the usual let's try to find the best hyperparameters or the best tuning for our technique, but rather across all these classifiers, what did it change in the information that I'm putting to these classifiers in terms of features? What did it change in terms of how it was behaving previously? So we use the Friedman test to use a rank-based analysis. That is a test used when you don't have much information or much knowledge about the distribution of your data, but you still want to answer the question, does this data follow a different distribution than that other data? So the idea is that when you have you have the technical term is full blocks, repeated tests with for K groups. So here we compare one group to the other. And what we found here was that for level 2 and 3, we have good values for P when we added some information on the hierarchy or on the LBP, but not everywhere. And surprisingly, not much for the level 4, which was where I was expecting the most detailed analysis, local analysis would result in more information, in better classification. So so the answer is, to come back to the first question we had, the consideration of symmetry was able to result in a different behavior for some groups, but we didn't have enough precision in our accuracy to reach a strong conclusion or to make a proposition to describe the observed behavior well. So we were able to reject the null hypothesis that symmetry was not relevant, but still we did not reach the answer that how did it impact, in fact, the results of the classifiers. So we because of the quadrant segmentation, we only work with a small sample. But I look at this work as we were experimenting. This is a small work, like a tiny amount of results at this point, but we hope this can be taken further. The idea is to extend this treatment over the entire data set, which then it should probably reduce or standard deviation when it comes to the accuracy, and then we'll be able to describe better what's happening. Also, we experimented with different ideas of distance when it comes to the LBP, and it probably is the case, it certainly is the case that some of these make sense and some of these are not that interesting to describe what we have. So feature selection and hyperparameter tuning at this point is interesting. And because of another work which will be presented later today at 11:40 by Gleison Costa, where the breast is reconstructed in 3D from the different images taken from frontal, 45 degrees and 90 degrees from each side. with that reconstruction, we have more information about each quadrant, because in this work, when we use it only the frontal image, some quadrants are only a tiny slice, a few pixels of a small region, and that is less information than we have about that patient. So I hope that you take from this presentation that this is a tiny exploration of some really big and interesting idea, is that the expectation of symmetry is something that encodes information that can be used by the classifier. Sorry for the time. I tried to go fast, wasn't able to. Is there any question?
Professor Reddy, you're on mute.
Well, if there are no questions, thanks for your time. I hope you took something interesting from this idea.
Professor Reddy, you're on mute.
I'm sorry?
Okay, thanks, Nuba. I think there is some issue with...
Okay. Okay.
Thanks, Nuba.
Thank you, Siva.
So moving on to the next session. Professor Chiru.
Good morning to all of you. Good morning. Thank you, Dr. Siva. So can I share my screen? You want to share one slide?
Yes, Professor Chiru.
Yeah. I will share my slide. Yes. Can you see the slide?
Yes.
Yeah. So I thought we are talking about this session, right? So so welcome all of you to this session. So this session will look at infrared images and application of AI on that, with a specific focus on non-breast applications. So we have 5 talks. I think we are running roughly 20 minutes late now. So so Dr. Siva, what would be the thing? Can all of us take 10 minutes each for the talk as planned, or is there some we should curtail some of the talks?
So we will have 8 minutes for the presentation for each talk, and maybe one question we can take for Q&A.
So basically 10 minutes as proposed, right?
Yes.
Okay. Yeah. So maybe then without further ado, let's get started. So the order would be as given here. Dr. Matheus from Ispahan, Dr. Fernandez from Universidad Politécnica de Madrid, I guess. And then so Mr. Mahmoud from Turkey and Mr. Mehmet Ergen from, again, Turkey, same university, Konya. And then lastly, we will have Dr. Ordun from Booz Allen Hamilton, USA. I hope all the speakers are here. So can somebody confirm the speakers are here, or the speakers are there? They can just say they're here. Unmute and say they're here.
I'm here.
Thank you. Thank you.
Catherine Orden is here.
Oh, thank you so much.
I'm here.
Okay.
I'm here.
Okay. Okay. So we are very good. So we all get started. So maybe can I invite Dr. Matheus to take us through RadioMICCAI feature selection from thyroid thermal images. I'll stop sharing. Dr. Matheus. Dr. Matheus?
Yes.
Can you share your screen? Dr. Manjunath, can you share the screen?
Sure. Have you got my screen?
Not yet.
All right. Yeah, we can see it now.
You can see it now?
Yeah.
Yes,
Okay.
please.
So, Dr. Manjunath, please start. We can't hear anything. Are you playing the
I'm
audio?
sorry?
Are you playing the audio as well?
Yes.
Okay, we can't hear you. So, can you present directly instead of recording?
Today, I would like to talk about our article with title Radiomics Feature Selection from Thyroid Thermal Images to Improve Thyroid Nodule Interpretation. Mammography, the risk of unnecessary invasive biopsy can be reduced, and by extracting radiomics feature, we can obtain valuable information about the underlying tissue characteristics. There are three categories about literature. We can talk about them. Studies based on temperature differentials, studies based on dynamic behavior of thyroid nodules, and studies based on artificial intelligence and machine learning. Studies based on temperature differentials, in fact, there is difference between benign and malignant nodules in terms of temperature, and there are promising results for discriminating between these two types of nodules. In this slide, you can see the table of studies based on differential temperatures. And for dynamic thermography, we can sorry, I think it's interrupted. Sorry about that. The assessment of temperature changes over time can be involved, and the thyroid region sorry, the internet is interrupted, sorry. I'm sorry. For studies based on dynamic behavior of thyroid nodule, Vardaska in 2019 had a study with title A Case Study on Dynamic Thermal Imaging Evaluation of a Thyroid Nodule, and Camargo in 2022 had an article with thermography as an aid for the complementary diagnosis of nodule in the thyroid gland. Sorry, my internet. And finally, artificial intelligence and machine learning techniques can offer automated and efficient means of nodule classification and can demonstrate impressive performance in distinguishing different nodule types based on thermal data. And the diagnostic capabilities of the thermal imaging and potentially can be promised, and the subjectivity associated with manual interpretation can be reduced. In this slide, you can see studies based on artificial intelligence and machine learning. Our data set was provided by the endocrinology and surgery outpatient clinics from Brazil. And for our study, 53 patients were selected out of 113 patients. Only 53 patients had their nodule identified, so we used only 53 images. Radiomics feature extraction. We use the radiomics feature extraction to provide additional information for diagnosis, treatment planning in various medical applications, and it includes statistical measures, shape descriptor, texture parameters, and other mathematical representations. For these radiomics feature extraction used for further analysis, pattern recognition, and building predictive models. The radiomics features involves histogram, gray level co-occurrence metric, GLCM, the gray level run length matrix, GLRLM, the gray level size zone metric, GLSZM, gray level distance zone metric, GLDZM, gray level size zone metric, GLSZM, gray level distance zone metric, GLDZM, and the neighborhood gray tone difference metric, NGTD, the neighborhood gray level dependence matrix. Here you can see a sample image. The pseudo-colored image is on the left, and the gray image is on the right. And you can see the cropped image, the region that the doctor identified. Extracted the radiomics features from the cropped image, and you can see in this slide, in these two slides. We had some limitations. One of our limitation is the data set, and because of the limited data set, we couldn't classify malignant nodule from benign nodule, and we can do it in future works. Our future works involves feature selection for reducing the dimensionality of the features. We use 3 different unsupervised feature selection techniques: principal component analysis, PCA, independent component analysis, ICA, and variance thresholding, VT. And also in future works, we can classify malignant nodules from benign nodules with different classifiers, And also we can compare the accuracy of different classifiers. And also we can use deep learning algorithms for the classification and compare the results obtained for these approaches. In conclusion, we can conclude that for enhancing the analysis of the thermal thyroid nodule, we can have some promises. We can provide valuable insight into thyroid function pathology and further research for validation. Sorry for the interrupting because my internet is not fast enough. And thank you for your attention.
Thank you. Thank you. I think there is one question we can take. It is in the chat. I will read this out. Please explain the process of cooling stress applied at the time of duration of its application at well the number of images taking post-stress application. So Dr. Menas, I will read the question again. Please explain the process of cooling stress applied at the time duration of its application as well as number of images taking post-stress application. So I think that the asking is that how did you cool stress during the time?
Actually, I'm sorry. Actually, we use the data set from the visual lab, and we use those images.
I see. I see. Yeah. Okay. Thank you. That explains all. I think we have no more time for more questions. But I think we can contact Dr. Menas directly. So thank you again. So let me invite the next speaker. Dr. Ismael Fernandez. Dr. Ismael?
Yeah, I'm here around. I'm going to share my screen. That's okay.
Yeah, that's absolutely.
So can you please confirm that you are seeing my screen?
Yes, yes. I can see the screen.
Okay, great. So just 1 second. So thank you very much for this opportunity. I'm very glad to be here. Sorry about the voice because it seems that I'm a little bit ill, but anyway, thank you very much for this opportunity. I'm here to present a work done by Victor Escamilla, Gerard, Raquel Barceló, Marc Madruga, and myself. We are belonging to different institutions like Thermohuman, the Technical University of Madrid, Biwolfis, and FC Barcelona. And what we aim to do is to relation the results obtained by thermography assessment in hamstring area and isometric test in amateur soccer players. Obviously, speaking in such a congress about thermography is not a point because we all are familiar with this technology. But just let mention that it's a non-invasive skin temperature measurement. And the result that we mainly work with is thermal symmetries measured in Celsius degrees. On the other hand, for those that are not very familiar with isometric tests, it's a quite familiar or normal test that is performed in high-performance institutions in order to measure the force production of different muscle areas. In that case, we were measuring a specific test for hamstring force production. The hypothesis is it's very common to obtain asymmetries in force production, and at the same time we work in thermography for injury prevention, speaking about thermal asymmetries. So the point here was to analyze whether the relationship between those asymmetries, the one provided by thermography and the one provided by the isometric test in a hamstring area in amateur football players were there. And actually what we did was to analyze 31 amateur soccer football players, okay? And then we follow the instructions provided by TSM consensus, analyzing those players before training with an 3560 EST camera, and then analyzing the images using Thermohuman software to get the asymmetries, the thermal asymmetries from the posterior leg region. After the thermography analysis, we perform a 90-90 hamstring isometric test, which is actually provided and described by Martin Lauri in an article in 2019. And we were measuring the percentage of interlimb differences in this area. So just explaining slightly how we proceed regarding temperature and thermography analysis, we were using ThermoHuman, which is software that enables us to extract the thermal asymmetries using artificial intelligence algorithms to automatically detect the different body areas and extract them, visualizing them in an avatar, but as well, obviously, extracting the raw data to perform statistical analysis. In that case, just to mention what we exactly extracted from the data from thermal asymmetries, as you can see, we divided the posterior view of the lower limbs in different body areas, and we were extracting the pixels and average temperature from external hamstring, central hamstring, internal hamstring, but we were also extracting the popliteus and the internal calf in order to have a comprehensive and localized differences in all the posterior chain. On the other hand, with the isometric test, as you can see regarding this formula, we were obtaining in newtons the force production from both sides, the right and the left leg, and then we were measuring the difference in a percentage, which is the normal value we use to test if there is any significant strength difference in a test. Okay. Regarding the results, we didn't find any correlation. Whenever we were analyzing all those regions, even those more distal, like popliteus or inner calf, none of the results were significant after performing the Kolmogorov Smirnov test to test the asymmetry, and then obviously the Pearson test that was analyzing if there was any kind of correlation between both variables. Those results are interesting because obviously, speaking about asymmetries, we might think thermography is true that has been related to other technologies that are measuring somehow the same things, like for example electromyography. Okay, and we strongly believe that thermography is a very good indicator of metabolism. Okay, also obviously it's a circulatory system and nerve system, and that has been mentioned and proved. And indeed, as I mentioned, we do use thermal asymmetries as an indicator of risk or of muscle imbalances that might be an injury risk. Nonetheless, it's true that previous studies, we just found one specific study performed by Teixeira in 2020 that was not finding neither any relationship or correlation between thermal asymmetries and isokinetic tests. So those results are aligned to the ones exposed and described by Teixeira. This not correlation might suggest that both tests are different and should be conducted independently, because at the end of the day, the isometric test is limited because isolating the multifactorial nature of force is very complicated. And thermography potentially should be focused more on the tissue state. Meanwhile, isometric tests should be focused on the neuromuscular state or the capacity of creating force. Okay. So the main conclusion is this one. Both tests, even if they seem similar, should be understood as different ways of assessing different things. We understand that thermography should be understood as a tool that can be used for measuring internal load on a weekly basis. I'm speaking here about high-performance athletes, which actually is measuring metabolic activity, that what we call in sports science internal load. So very focused on analyzing local state of the tissue. Okay. On the other hand, isometric tests should be done punctually, mainly when we detect something that is not going correctly, and we think that the problem is regarding the force. It is true that at the end of the day, as you saw in the picture, we are analyzing the force in a very specific position, and force production is depending on a lot of different factors like coordination, position, train or not train capabilities. And that, therefore, we understand that isometric test is very interesting, but just performing sometimes and focusing on the muscle external behavior. Okay, so that being said, I really hope that I stick to the timetable. I acknowledge all my colleagues performing this article and work, and I thank you for the organization of this Congress. Very keen on answering any questions or doubts if there is any. Thank you very much. I'm very open to answer your questions.
Thank you. So I think I can see one question in the chat. It says, what thermal features are used for assessment? So do you want to...
Thermal features?
Yes.
What do you mean? The thermal metrics?
I was just reading it out, so I think the person who is Mr. Ronak, Didia, you want to just quickly say?
Yeah, so the temperature difference which is taken, so one is like mean temperature difference is taken to calculate the asymmetry, or any other features are as well calculated.
So we are collecting, so segmenting the image, extracting all pixels from each region, and creating, in that case, we are using average temperature of each region of interest. So we are using this metric. It's true that the number of pixels depends on the size of each ROI, but we use average temperature to calculate the asymmetry. I don't know if I answered your question.
Yeah, thanks.
I think we have to leave it there. This is one of the downsides of having an online meeting like this. In person, we could have caught up after coffee or tea, but thank you. So may I invite the next speaker, Mr. Mehmet Sevik from Konya University, Turkey. Mr. Mehmet Sevik.
Yes, I'm here. I share my screen.
Sure.
Can you see my screen?
Yes, we can.
Okay, I'll start. Hello, everyone. First of all, thank you for joining my presentation. I would like to briefly introduce myself before starting the presentation. I am Mehmet Sevik, and I have been working as an artificial intelligence and image processing engineer at AI Vision Tech for about 2 years. Additionally, I am pursuing my master's degree in these fields at Konya Technical University. Today, I will be presenting our study, Performance Evaluation of Convolutional Segmentation Models with Human Hand Thermal Image Dataset. To begin with, I would like to provide a brief overview of the topics which I will be covering in this presentation. First, I will discuss what thermal imaging is and how it is used in the field of medicine. I will also delve into the significant and technical development of thermal image segmentation. Next, I will explain how two-hand thermal images used in this study were acquired and introduced to the dataset. Finally, we will evaluate and discuss the segmentation models trained with this dataset. Like any object, the human body emits radiation based on its temperature. This emits thermal energy is referred to as infrared radiation. Infrared energy with wavelengths between 8 micrometer and 14 micrometer is utilized to obtain the temperature of objects. Thermal imaging is developed based on this fundamental principle. Anomalies in the thermal distribution of the human body can be indicative of various illness and injuries or fatigue. Particularly, thermal asymmetries in the hand region can manifest in different neurological or circulatory disorders, such as carpal tunnel syndrome. In order to detect disorders in the human body using thermal imaging, regions of interest need to be separated from the background. When it comes to method used for thermal image segmentation, they include thresholding techniques, clustering algorithm like k-means, and deep learning approaches. In the study, convolutional neural network-based architectures are employed for the segmentation task. In the study, we introduced the human hand thermal image datasets referred to H2TI. I would like to explain the process of obtaining this dataset. Thermal image soffents were obtained from 8 volunteers. Filler 1 Pro and Filler T 540 EST thermal cameras were used for thermal imaging. A total of 4 seasons were conducted with the 8 volunteers over 2 days, capturing both their left hand and right hand. Some captures were performed using both cameras simultaneously. Each capture was done with the palm of the hand facing upwards. The 106 thermal images obtained were labeled into 7 regions. These hand regions were selected considering areas evaluated in previous hand thermal imaging studies. The data set was divided into 70 training, 20 validation, and 16 test samples. Data augmentation techniques were applied to training and validation sets, which increased training data 560 and validation data to 60 samples. Each hand region was labeled as a binary image in the model's output, representing the respective dimension. This was done to facilitate obtaining the masked image of the desired hand region when thermal evaluation is needed for this hand. A total of 12 models were trained with the introduced dataset, utilizing 4 different model architectures. These model architectures were constructed using 4 different backbone structures. I will explain why these architectures were chosen shortly. The models include UNet, PSPNet, FPN, and LinkNet, while the backbones comprise ResNet 50, Inception Vol 3, and FGNet B7. All model architectures follow an encoder-decoder structure consisting of 4 convolutional states in both the encoder and decoder parts. In this section, I will explain why these model architectures were chosen. FPN is believed to capture the weak color change information that delineates the boundaries between the tenar and hypotenar area. Tenar is that hand muscles area, and hypotenar same like. Using different feature pyramids, UNet was selected based on its success with limited medical dataset in previous studies. LinkNet is feature level bypass feature was chosen to its success in both feature extraction and localization task. PSPNet with its peeling pyramid can capture both global and local features, which was made important for segmentation similar, hence since backbone structures were chosen considering their difference in convolutional approaches, based approaches actually in the segmentation models. Before training the 12 created models, hyperparameters were set as shown in table 1. A batch size of 16 and 150 epochs were selected. No significant accuracy improvements were observed with different epoch, more than epoch values during training. Input and output size were adjusted according to model structures. Binary cross entropy and Jacquard index were chosen as loss functions. While various evaluation metrics were considered, the result for mean, IOU, and dice coefficient, which are commonly used in segmentation tasks, will be highlighted. Upon examining the sample outputs, it becomes evident that FPN and PSPNet based models in particular exhibited difficulties in background labeling, that its imaging, some fingers are background labeled in this models. UNet and LinkNet-based architectures demonstrate better performance in background labeling. Evaluation metrics reveal that the LinkNet efficient net model achieves high success with 18.4.5% mean IOU and 19.1.4% dice coefficient values. And the H2TI dataset consists of a relatively limited number of samples. In the future, efforts will continue to increase the dataset size. Additionally, new segmentation models will be introduced or models created. A comparison will be made between the existing models and the ones to be developed. Moreover, this improved segmentation models can be used in the evaluation of the disabilities like carpal tunnel syndrome or same like nerve pressure syndrome, opening the door to further research. That concludes my presentation. Thank you for listening. Below you can find my contact information. Feel free to reach out to me regarding any question or topics you would like to discuss.
Thank you. Thank you very much. Any one quick question? Okay. So I was, okay, let me read out a question from Sajia Sheikh.
I will, right, okay, I can see.
Yeah.
Chat.
So can you just answer the question? The question is in the chat.
Okay, can I answer a question via message from
Oh, sure,
the
no
chat?
problem. Yeah. Thank you.
Okay,
Yeah,
thank you.
Thank you. So so now let me invite our next speaker, Mehmet Ergen from the same university. Mehmet Ergen.
Hello, can you hear me?
Yes, I can hear you.
Yep. So I can share my screen and start, I guess.
Please.
Can you see my screen right now?
Yes, we can.
Yeah, perfect. Hello, everyone. First of all, my name is Mehmet Ergen from Konya Technical University from Turkey. And thank you very much for such nice conference and for letting me present our study in this conference. I'm going to present you our study named Evaluation of Deep Learning Models for Lower Extremity Muscle Segmentation and Thermal Imaging, which we made with Professor Murat Ceylan, Associate Professor Ahmet Bayrak, and Mr. Mahmut Çevik just before me he presented, and by myself. According to a study, 764 players were injured in the Premier League during 2018 and 19 football season. And all these injuries costed around 11 million pounds, which is approximately 290,000 pounds per injury. Additionally, injured players missed matches, and this caused lost points for football teams. In order to prevent these injuries, many methods have been used, including infrared thermography, which we also used in our study. In our study, we monitored professional football players from Turkish Super League and 9 muscle regions from lower extremity thermal images are determined. All these muscle regions were selected according to the, of course, common muscle injuries in football players. Football players were observed during the infrared thermography, and after that, to segment the muscle areas, UNet, FPN, LinkNet, and PSPNet segmentation models were used. You can see the example training data and the masks of the muscle areas in the picture. After that, you can see our training environment. We have used TensorFlow, Keras, and UNet, PSPNet, LinkNet, and FPN models. Also, for loss function, we have used binary cross entropy, and for accuracy criterion, we have used intersect of union, F1, precision, and recall. UNet is a common segmentation model for especially biomedical images. It consists of encoder and decoder parts. The encoder generates feature maps by compressing the input image, while the decoder creates the segmentation map by resizing these feature maps. At each step, decoder section feature maps from the encoder are combined to help to preserve the details. PSPNet is a model which is commonly used for scene context segmentation, actually. PSPNet uses the dilated convolution operations to obtain multi-scale feature maps and combines these feature maps with scale pyramids. In this way, it can effectively capture the context of objects at different scales. PSPNet uses a unique pyramidal model which improves pixel level segmentation results by combining feature maps at different scales. Of course, pixel level segmentation is important for us because we are doing a study on pixel level to segment the muscle areas. That's why we have chosen PSPNet. LinkNet we can call more lightweight model than UNet because it is also commonly used segmentation model for biomedical applications. The key feature of LinkNet is the merging of linked encoder and decoder blocks. The encoder uses depth-based convolutions and downsampling operations to learn these features in the input image. The decoder process scaled feature maps by resampling and merging to obtain higher resolution segmentation maps. And LinkNet adds the direct connections to the output in each decoder block. These connections help prevent feature loss and provide better location accuracy. And our last model is FPN, which is called Feature Pyramid Network. Is a deep learning model used in object detection and segmentation also. FPN uses convolutional neural network architecture and has a pyramidal structure like PSPNet. The main purpose of FPN is to combine features at all scales to improve object detection performance. For this, FPN creates a series of interconnected feature maps, and higher level feature maps are combined with lower level feature maps. This results in a better feature representation across different sizes and scales of objects. When we check the results of our study, as I mentioned before, for accuracy criterion, we have used intersect of union, F1, precision, and recall to measure how successful the segmentation results were. So when we check the results for each muscle area, we can see that FPN and UNet has the best results in our segmentation models. For example, when we check upper adductor, we can see FPN has the best result and UNet comes after that. And quadriceps rectus, in most of the accuracy criterions, FPN comes the first and UNet comes the second. In some parts of the muscles, FPN comes first and LinkNet comes after that sometimes, and sometimes UNet comes first and FPN follows that. When we check vastus medialis area, for example, FPN comes first and UNet comes after that, and LinkNet comes third. And we are calling that one first, second, and third. But these are almost a perfect segmentation for all of the models. When we check, for example, gastrocnemius soleus area, FPN comes the best result, gives the best result to us, and after that, LinkNet gives the best result to us. So when we check the other parts, again, FPN has the best results for the segmentation. So when we check the segmentation results, like to see how it was successful, you see the ground truth. You see the origin image in the A section, and there is the ground truth masks for all muscle parts, and there is the FPN prediction, and there is PSPNet prediction, there is UNet prediction mask, and LinkNet prediction result. You are seeing that. And as you can see, almost in all regions, FPN has the best results. There is also vastus medialis, patellar area, and gastrocnemius soleus. There is the ground truth mask, and you can see FPN and UNet has almost similar results. And you can see here tibialis anterior, fibrillaris, and ankle and feet region. And we can see in FPN and UNet has the best results. Also in this section, PSPNet and LinkNet has good results as well. So in conclusion, in this study, we have used 4 segmentation models to segment muscle areas in thermographic images of football players. so that we can examine muscle areas more clearly and detect muscle problems easier. In this way, we can prevent injuries even before they occurred. Our study demonstrates that these models can achieve high success rates in muscle segmentation, making them valuable tools for injury analysis and evaluation in athletes. Our research emphasizes the importance of advanced imaging techniques in sports medicine and lays the foundation for the future advancements in injury prevention and personalized treatment plans for the athletes. Again, thank you very much for your attention. I hope I was in time and didn't take your time too long.
No, you're right on time. So we can take one question if any of the.
Yes, of course.
So I see a question is in the chat. It says, how were ground truth masks generated? I believe the question is to you.
Yes, of course. Our ground truth masks were generated by hand with the aid of the professional physiotherapists of the football teams.
Thank you. I'm sorry the time is not there to discuss in detail more. So, but I would request others to send messages. So, let's thank the speaker once again and invite the next speaker, Dr. Catherine Ordun. Dr. Catherine.
Hello. Let me go
Hi.
ahead and share my screen.
Sure.
Can you hear me clearly?
Yes, we can.
Okay, great. Hi, everyone. My name is Catherine Orden. I'm from Booz Allen Hamilton in the United States, as well as the University of Maryland and Baltimore County. The majority of my research is focused on generative imagery, particularly with thermal images. Today, I want to talk a little bit about thermal facial emotion recognition, which is the key subject of why I'm studying the generation of thermal images. Now, FER for thermal physiology has a very long history that started in the 1960s, and there are some seminal works and review in this paper we published a couple of years ago at AAAI. But the basic idea of the human face is that there are vessels that underlie the subcutaneous tissue of our facial skin. And when they are innervated in response to some type of hormonal stimulus, let's say, for example, you're embarrassed and your face gets flushed and you feel red, this type of heat from the innervated vessels can be detected through long-wave infrared. And here is just a sample of different types of FER with thermal imagery, from bioheat modeling to maternal empathy to the detection of exercise-induced fatigue. But there's a host of others, including emotive states, stress, and even deceit. This makes it a natural selection to use thermal imagery in the first ever chronic cancer pain data set in the United States National Institute of Health, which is America's top health government agency in a clinical trial. And some of our work is published at NeurIPS a couple of years ago, where it is a multimodal data set where using your smartphone, you can extract from a single video the frames, 3D landmarks, wellness scores about how pain would interfere with your sleep and relationship with others, the wave file, acoustic statistics, spectrogram, and a host of other types of multimodal data. Now, another aspect of having this type of data set is that we also have a thermal camera that is equipped at the actual cancer lab. And in this particular setup, you may be familiar with different types of thermal cameras. Now, there are dual sensors that are used for drones, where on a single dual sensor, such as a FLIR Duo Pro, you can have embedded a thermal optic as well as a visible optic, which will snap the picture or video simultaneously in space and time. But for many reasons, especially for issues like biometrics, many of these visible thermal data sets are captured using two different cameras. Let's say a Panasonic Visible and a FLIR thermal camera. This is also endemic to issues of automated driving, such as Teslas. Now, the problem that occurs is that naturally with a subject who is sat being the subject of two different cameras, there will be opposing points of view. And what will happen is that the visible V and the thermal T will be misaligned. To your human eye, they may look like they are the same scale, but they are not. And this one example, which is not the cancer data set, but this is from the Army Research Lab DevCom data set, the thermal face for this gentleman is very, very small and squeezed. It is not the same scale as the visible image. And for medical reasons, we need to make sure that we are pairing visible and thermal images. We know that the thermal image carries a lot of information that is not visible in the visible spectra, but because of space-time, because of biometric information, we must keep them exactly paired. Now, what we learn here, especially when we deal with generative algorithms, is that if the images are not aligned, if they are off-center, and you feed off-center misaligned images to, let's say, a generative adversarial network with the task of something like image-to-image translation, what will end up happening in GAN V2T is that you are going to generate the wrong thermal person. And from a biometric and medical perspective, that will not help you because it is not the right identity. Now, the reason why we're interested in this particular approach is that manual methods that are machine learning, classic computer vision, such as using binary thresholding, SIFT, SIRF, Lofter feature detectors, even using something off the shelf like the Google Face Mesh, they will not work on thermal imagery, as you know, because they were trained on RGB images. Even texture, intensity, and hue make it difficult to compare images that are cross-spectral in the visible and thermal realm. As a result, we can actually use something like a generative adversarial network to accomplish this task. Now, before I go into this for the sake of time, I urge you to look at this paper that we will be presenting next week in Kuala Lumpur at ICIP that provides all the technical details, the mathematics, the optimization algorithms, and mechanics of this algorithm. The most important thing to emphasize here is that generative algorithms in this hype age of ChatGPT and diffusion models and AI art, they can do much more than just make pretty pictures for entertainment. They serve a vital purpose as an unsupervised tool. In my previous example of alignment, we have no scale. We have no parameters by which to align a thermal image to visible. Nobody is providing the affine matrix. No one is providing a reference image. As a result, we can use something like the VTF GAN that we generated to perform the task of image-to-image translation, which is taking a visible image and translating it into its thermal counterpart. Here we have a classic GAN setup. We have a discriminator and a generator. The generator is a customized UNet where we add blur pool, which are anti-aliasing layers to prevent from stippling or checkerboard patterns, which are a fact of hallucination, and a patch GAN discriminator that outputs an auxiliary loss based on a relativistic loss. This is a little bit similar to a Wasserstein GAN loss. It is different from a typical KL or Jensen-Shannon divergence loss. Here, the most important aspect is that there are several losses that compose and control the generation of a high-quality B-hat fake thermal image. This is beyond only using the pixels, but it also looks at the Fourier transform, a discrete Fourier transform, to be able to also understand and have the algorithm learn low and high frequency edges, since we also want it to learn in low, none, and hard light. To that vein, we also developed a visible to thermal facial diffusion model. Diffusion models are the aspects of algorithms that are used in components like Midjourney, Stable Diffusion, and AI art as well. It's a completely different beast and mechanism than GAN. Here's some samples from a different data set where the first column is the visible image, ground truth. The second column is a thermal image, ground truth. And the third column is our generated images from VTF GAN. Notice that they are almost identical to the thermal image. Now, the second component that we introduce for the cancer faces is something called Vistamorph. This is also a modern take on homography, which can be often seen in biomedical tasks such as aligning CT or MRI scans. However, this is a little bit different because we deal with two spectra, and we're also including the GAN in this particular setup, which is why I introduced it earlier. First, we get the real visible image A that's provided in the data set, and we translate it using the VTF GAN G1 into the fake thermal image B hat. We then go to a next flow where we get the real thermal image. Notice how it's not aligned to the A, it's off center and it's smaller and squishier. And we pass it through a second VTF GAN to generate what we call these intermediate visible images. Here's an intermediate A1. This is extremely important because we pass it to an architecture that was developed by DeepMind called Spatial Transformer Network, which we modernized using a vision transformer. The goal here is to be able to essentially project the thermal image into a visible spectra, A1, so that we can learn phi, which is the affine matrix. This is essentially the coordinates, the parameters, how much shear, angle, and volume needs to be morphed in order to get the thermal image, B, to actually scale to the visible image A, which we call B sub R. Using these two approaches, the VTF GAN and VistaMorph, we trained 29,500 VT facial pairs from the cancer data set. There are 22.75 for the train set, consisting of 34 subjects, and 6,891 for the 10 subjects. Again, I urge you to check out our NeurIPS paper, where there's a lot more detail about the data set itself. Another component is that we have an MLP, which controls for finer granularity about different edges, frequencies, and smaller minutiae of the VT pairs. Here are real samples from the cancer data set. For a data set like this, especially in the United States, we have to go through something called an IRB, which is an institutional review board. This is a very serious matter because these are medical data from cancer patients whose identity is very, very protected under US government laws. So these images that I'm showing you are fully consented, but it took about 2 to 3 years to actually have the IRB approved from the US government. So here you can see a thermal face and a visible face. It is now easier to appreciate how warped and how off scale the thermal and the visible are. They are very, very grossly off center. When we use our approach VistaMorph, they are now registered, REG dot, which demonstrates that the thermal image has now been registered with a visible. We can see some more examples here with a difference map, which basically is intended to show kind of the superimposition about the different features as they are overlaid across each other. Our registration scores use SSIM, normalized cross-correlation, and mutual information that basically captures how much information is similar between the visible and the thermal image before and after registration. Also, our GAN scores using FID and LPIPS also are improved after we train the GAN on the registered pairs, not the raw VT pairs. This is very challenging because there's a lot of older individuals in this data set. Some of them have masks during COVID, has very low resolution, very grainy texture. A lot of people are looking down. So many of these images actually have non-frontal alignment. We also have done some biometric analysis that we presented at IJCB, which is an international biometric conference last week in Slovenia. And we can actually prove through extracting vessels from thermal images that anatomically, after the thermal image is generated, once it is aligned with our method, that the vasculature actually retains similarity, proving that the identity is continued once we register and align the thermal images. You'll also see on the bottom some examples from the diffusion model. Now, while diffusion models are all the hype right now, there's still a lot of ways to go. They're quite computationally expensive, and they require a lot of control in terms of variance, schedule, and optimization. You can see here that geometrically, they do produce a face. However, because of thermal imagery, the particular pixels and the heat distribution is inconsistent with the ground truth. In summary, we introduce a completely unsupervised approach using GANs, vision transformer, and spatial transformer networks to automatically align visible thermal facial pairs using VistaMorph and VTF GAN. Why is this helpful? Well, if you consider using something like OpenCV or even using your own hand for Photoshop or NumPy, trying to manually align faces and zoom and crop, this is infeasible when we're talking about thousands and dozens of thousands of faces. Further, there's dual use for automated driving data sets where there are visible thermal street scenes as well. So this allows for rapid alignment that surpasses manual homography techniques. We train them on the ISS dataset, which is the first use clinical trial on chronic cancer patients. And then it offers more consistent biometric identity, which I urge you to check out our IJCV paper for more information about that. And thank you very much. Feel free to reach out to me if you have any questions or if I can be of any help.
Thank you. Excellent. So any question for Dr. Catherine?
I have a question, if you might.
Go ahead, please.
Yeah, hi. Yeah, great talk, Catherine. Do you think some of these techniques are also applicable to, let's say, registration of breasts? Because when you try to do a longitudinal analysis of thermal breast scans, no, there are several variants of positioning and so on. Have you tried for other body parts?
Well, in our paper, our IJCD paper, I actually demonstrate that it does work on non-facial domains for automated driving street scenes. So for breast images, I imagine it would actually work because this is not only domain specific to faces, it can work outside of that domain. The basic idea here, and the reason I feel confident about it, is because there is no reference image and there is no target, so to speak. The whole kind of key of this game is to be able to project the visible image of whatever spectra you want from A into, project the thermal image B into a visible counterpart A. So that means that we could even go B to A or A to B. This could be visible thermal, thermal visible. This could be near IR and visible. This potentially could be CT and visible. I have not tried it on mammography, MRI, or CT scans, but I think that this has some promise because I have studied a little bit about voxel morph, for example, and some other homography techniques, and those work pretty well. But this one works faster than you would expect on thousands and thousands of images. So I think it's worth a try.
Thank you. Good job. I think Alex has it.
Yeah, Catherine, nice work. And I'll probably gonna pick on this at the end when we talk about the challenges in terms of whether we could use this in the future for setting up challenges either on synthesis or on developing methods based on synthetic data as a way to overcome the limited data we have available. But the question I had is, if I understand correctly, the method that you presented is focused primarily on reproducing the appearance of the images, right? But it doesn't necessarily guarantee that these images will be, from a physical point of view, plausible.
Yes, that's exactly right.
Is there a way you could think about this approach being expanded so that physical consistency applies, particularly knowing that these are thermographic images that have some conservations that need to be fulfilled, etc.?
Yes, I think this is one of the key limitations, and there are some, I do have some ideas about that. In this ICIP paper that I'm referencing below, you'll see that there are there are 3 or 4 data sets that I use. Unfortunately, VT face data sets are extremely limited. So we have the DevCom data set, and I have a point as to why I'm kind of listing all this. We have the DevCom data set, the Eurocom data set, the Carl data set. There's a whole bunch of others that actually I listed in this AAAI paper. The reason I'm mentioning this is because all of those data sets, including even this data set from the cancer study, we do not have labels on them, meaning that we don't have like hot coffee or hot cheeks, just exercised, 37 degrees. So we don't have these labels to be able to allow us to basically use a GAN to generate an image that would emulate someone who had just exercised outside or ran on a treadmill. So the generation of these images are only as good as the data that has been used to train the GAN. However, I do think that, funny enough, a lot of these text-to-image diffusion models that we're seeing from like AI art, I do think that we could kind of reverse engineer it in a way so that we can generate captions for thermal images to say nothing that is incorrect about the scenario, but like, let's say, for example, this man right here, his thermal image. If, for example, his nose was really, really dark, we all know that his nose is very cold. We could use something like a generative model to create many, many captions, many sentences, like image captioning models that say man with very, very cold nose, man, older gentleman with hot cheeks, something like that, to confer some labels, because without labels, there's really no way that if we were to use this GAN live, that I could guarantee that it is correctly generating a thermal image of your moment in time. This is actually a big aspiration of mine. This is one of the reasons why my group has been generating, or rather studying, this type of algorithm.
But Catherine, if I may just follow up.
Thank you. If I may say, because we are running against time and already there is some follow-up sessions. My apologies for breaking this up, but I think great talk, and I hopefully please carry on the conversation. So thank you again for this session. It was very encouraging and exciting to see such new results. And thank you for having me as the session chair. So thank you all.
Thank you. There's a slight change in the agenda, Siva.
Yes, so we will have panel discussion now, followed by the data challenge and vote of thanks. So moving on to the panel discussion.
Hello. Can you hear me?
Yeah.
Yeah. Hi. Siva, can I start?
Yes.
Okay. Hi, everyone. Welcome to the panel discussion, and it's exciting to moderate this session. I'll quickly jump into introducing our 4 panelists. I start with Dr. Geetha, who is CEO and founder of Niramai Health Analytics. She holds a PhD from IST and has done her MBA from Kellogg School of Management. Prior to Niramai, she was AI Lab Director at XRCI, and she has received many international and national recognition for innovations. And very interestingly, she was part of Forbes list of top 20 self-made movement. Thanks, Dr. Geetha. Moving on, Dr. Ismael, who is CEO and founder of ThermoHuman. He's MBA in International Business Administrator, and interestingly, he has done a PhD in Sports Sciences, which is very interesting. And he has around 20 plus experience in various professional academic experiences in various countries like France, Spain, Ireland, etc. Thank you, Dr. Ismael. I'll also introduce Mr. Johnny. I hope I have spelled your name correctly. He is CEO of the Thamidas. He has done his BSc in Structural Engineering and MSc in Management. His specialty is basically international business and business management and global solution provider. Thanks, Mr. Johnny. And Dr. Brioschi, who is CEO and founder of Inframed, and he's also a professor at University of Sao Paulo. He has done his postgraduate in clinical thermography. He is a postdoctoral fellow in Department of Medicine Neurology, and also he's president of Brazilian Association of Thermology. Thank you all of you for joining this panel discussion. So as I mentioned about these 4 startups, 4 CEOs for these 4 startups, interestingly, if you see, AI has been used most extensively in medical imaging. So how do you guys came up with using AI, the challenges you found or faced using AI in thermal imaging? Where all and how do you start using AI? Who wants to go first?
To start.
Yeah.
Okay. So I think, what we do at Niramai is pretty well known. Thank you, Manju, and thank you all for joining this. So we obviously use AI for analyzing breast thermal images. Of course, we talked about a lot about breast thermography earlier in the day today. And given that there are 400,000 temperature points per person that we end up measuring, and given that every color point could be any of the 2,000 different colors, it's always very hard for human eye to differentiate between, let's say, a 34 degree and 35 degrees Celsius, just to a thermal image. So using all this high thermally sensitive information as temperature points and analyzing it using AI is what we do at Niramai, where we've developed this new method of detecting breast cancer, which is AI on Thermalytix, thermal imaging called Thermalytix. So there are a couple of things. So one place where we use, we have about 20 different AI models that run in this. So one of the main places is, of course, to determine the classification of the different features as to whether it is malignant or likely to be malignant or benign. But what is also not obvious is we have a bunch of algorithms which determine the quality of the image as well. So whether all the views have been taken, so to identify the view itself, right? There's a deep learning model to figure out what angle of incidence is the person positioned. We also have an AI-based algorithm to check whether the cooling has been done correctly, focus has been done correctly, etc. So the image quality check, a bunch of AI algorithms. Then we have a bunch of AI algorithms to extract features as well. So one of the new set of features we extract is what we call as vascular radiomics. So where the blood vessel extraction also uses AI deep learning based models. And then of course we have explainable AI with 3 or 4 different classification models which help us identify the rough cause for making this decision also, because it's not just enough to say yes it is malignant, no it is not. We have to have it to be able to explain to the doctor what is possibly the reason why the machine is saying yes. So we have different classifiers which tell you whether it's because of vascularity that we are saying it's likely malignant, or is it because of high thermal activity alone with a focal increase in temperature, or is it because of including the risk of the patient as well, right? So some kind of an ensemble learning as well. So all of these places we do use AI, and so AI is a very, very critical component of Thermalytix, which is the primary product of Niramai. I pass on to maybe Ismael. The fourth panelist is not visible here.
Thank you for that. So in Thermohuman, we have 3 main approaches to apply artificial intelligence. The first one is regarding the data processing. So we use algorithms to automatically analyze the thermal images and detect the background and then the body areas. So we do a segmentation extracting exactly the same position and area in each individual, regardless of their anthropometrics characteristics. Okay. The second one is regarding the metrics. As in Niramai, we also analyze the quality of the data through different variables. So the size, the distribution, so we can know if the image was correctly taken or not with those automatic algorithms. And the third approach, and this is potentially the most interesting and the one we are digging more and researching more, is on the interpretation. So what those results mean. In our application, which is mostly focused on injury prevention and also fatigue identification, the algorithms are focusing on automatically understanding if the metrics are concerning from a injury risk perspective. So evolution, epidemiological factors, the regions, the progression over the time, because yes, we normally take several images of the same person over the time. And then regarding fatigue, we also analyze the tendency over the time to understand if the results are out of normality, and providing insights to the practitioner to understand what those metrics might mean. And now I think I have passed the ball to maybe Marcos or Joni, whatever it is.
Thank you, Ismael. Thank you, Geetha. Congratulations, Geetha, for your United Nations speaker last week.
Yeah, I'm trying to make thermal imaging really known to everybody. Please go ahead.
For us, it's an honor to be here in your meeting again. And so I can say that Infrared Med is not a startup, because we have 24 years doing infrared imaging. Our focuses are in medical diagnostics, telemedicine, and sure, we are actively seeking advanced solutions for breast cancer diagnosis with artificial intelligence. Exploration involves incorporating thermography with ultrasound, elastography, mammography, to enhance the precision of breast cancer detection. We went to understand diverse thermal partners associated with breast health, considering factors like genetic mutations, ethnicity, lifestyles, and we have an interest also to differential diagnosis with thoracic neurology, thoracic outlet syndrome, mixture with breast images. And also we have interest in sport medicine, but not only in lesion, but in brain neuroplasticity and temperature variations of the brain, to looking for behavior or cognitive plus physical performance conditions associated with sleep disorders or nutrient deficiencies as vitamin D and C, and enzymatic disorders of the liver in the athletes. So, and also we are dealing with diabetic foot complications, exploring surgery, recoveries, nutritional deficiencies, neuropathies, peripheral artery insufficiency. So the aim is to bring to the doctors and the hospitals and clinics a medical thermography to advance in radiology and in public health support.
Thank you.
John, you're on mute. Yeah.
Let's try again.
Yeah, I can hear it. Yeah.
Okay, great stuff. So everybody's doing impressive work, really. I'm delighted to hear that you've taken huge leaps on advancing the use of thermography in medicine. That's great. So how we use AI is quite specific. This is our first generation AI, and it's currently undergoing clinical tests with the NHS in the UK. So we focus on solving the DFU. So diabetic foot ulcers are a huge problem worldwide. And one of the great things about diabetic foot ulcers is that they can be easily detected and prevented before they appear. So 75% of the diabetic foot ulcers can be prevented. And this prevention is what we are focusing on. So the way we are using AI is in our clinical study is that patients who have diabetes and are in high risk of developing a diabetic foot ulcer have been given one of our home imaging devices to take images of their feet every day at home. So it's not done by professionals, but it's done by patients themselves. So they take 2 images every day, and these images are compared. First of all, we overlay the feet, and then we look at the contralateral points. We take 110,000 thermal points, and then we observe the data. And if we find a temperature difference of over 2 degrees on the second day on the same spot, that's when we're going to send an alert to the hospital. So this is the AI is detecting the shape. It's overlaying the images, and then we use our algorithm to calculate from the Kelvins, calculate the temperature difference, and then it's just simply sending an alert to the hospital that this patient has got a temperature difference. And the initial results have been absolutely great. 60% of the patients who are enrolled in the study have actually received phone calls from the doctors, and with simple instructions like, are you using your offloading insoles, or did you forget to use your proper feet, shoes? They've managed to eliminate that temperature difference from the following thermal images. And also we've managed to detect a couple of ulcers at the very early stage. So not all ulcers can be detected, only the ones that can be are caused by mechanical friction mostly, they can be prevented. But the ones that are caused by inflammation, they are easier to treat if we catch them early. So this is how we use AI. It's in its first generation. We are reaching halfway point on the clinical study, and we have applied for a break to upgrade our AI model, because we are undergoing a second round of study session for the current AI, and we believe that the new model is going to be much improved and it's going to give a better user experience. Okay, so that's it for now. Thank you.
Thank you. So, Mr. Johnny, you raised a very interesting point about clinical studies, right? So, what were the most key learnings during the study? And this question is open for everyone. So, because you raised the point, I would like you first to answer that. Like, what are the key learnings in the studies we take here?
So, this is called the feasibility study. So, for the NHS, the key target has been to verify that patients can adhere to daily imaging. So basically using technology to help prevent something that would impact their health from occurring. So that's been their key target, learning the adherence. For us, it's been to validate that the AI model works and to basically learn how to make the optimal imaging device to help the people to follow the protocol, the imaging protocol, and make it as easy and comfortable as possible. And this is also why we are upgrading now the AI to improve the user experience, to make it easier for them to adhere to the daily imaging.
Thank you, Mr. Geetha, you want to add anything on that?
Yeah, sure.
Yeah.
Whom did you say?
Dr. Geetha.
Okay, yeah, sure. So basically, yeah, clinical research and clinical validation is absolutely critical before we take things to market, and commendable work on diabetic foot there, Yoni. So what we have done is, of course, ours has been like 7 years of research now. So initially, of course, we had to do the clinical research to collect the data itself, because there was no readily available breast imaging data set with absolute golden truth, as we could say, right? Biopsy results. So we initially, the first set of one study that we did was mainly to image women who are known to be positive, biopsy confirmed, take those images, use that as training data set. In addition to normal, thermal images. And once that is, of course, that is not considered studies, but basically just to collect the data. After that, we have done now 4 clinical prospective clinical studies where every person comes in, takes a thermal imaging test, and the Thermalytics gives the output. Same person in a blinded fashion goes to mammography and or ultrasound, depending on the density of the breast, and decision of the radiologist to say which of the 2 standard imaging tests has to be taken. And then if she's positive, she goes for a biopsy. So we have done the clinical study comparing with the biopsy results for positive patients with the Thermalytics output. And I'm very glad to mention that we've got really, really promising results in all the 4 studies we did. One is a multi-site study only on symptomatic patients. Another is a single-site study with both symptomatic and asymptomatic. And another one is more in a tertiary care study, tertiary care center. And we've also done another study, which is more field study, where we've just imaged about, this was published in Lancet Oncology, 14,000 women screened in the field. And of course, they only had clinical breast exam or a self-breast examination or self-described complaint as an additional kind of a parameter. But the main idea is to have a look at it like a funnel, like people who are positive in this,
how many of them get confirmed as suspicious in ultrasound, and then finally biopsy. And then we've done this type of analysis in 3 different states on 10,000 patients, 7,000 patients, and 14,000 patients, 3 different settings. And it's been really, heartwarming to see how, Thermalytics is able to pick up, touch wood, we have not missed any cancer that has been detected by either an ultrasound or a mammogram in screening population. And also with reasonably good false positive rate that enables us to use it even in the field, not too many. For example, a 10,000 people scan got about 200 people into the hospital, which is pretty good from a real field village remote setting perspective. We've also had even better results in terms of fine-tuning the false positives, but this itself is looking pretty good. So, before I pass on, I encourage you to take a look at our 36 publications on niramai.com/publication.
So I just wanted to ask Professor Brioschi, as a medical doctor, what are your views on clinical studies?
In our case, the protocols, the image process is conducted by specialized medical doctors who have undergone a comprehensive 400 hours training program. It's almost 1 year in medical thermography at the São Paulo University. And the protocols we follow have been established in collaboration with the Artificial Intelligence Infrared Imaging Alliance. That is a strategic partnership involving the Brazilian Association of Ophthalmology, American Academy of Ophthalmology, and Korean Society of Ophthalmology. And in our studies include patient preparation. We use specific equipment with human calibration, not for industrial application. And we follow the standardized procedures for image acquisition.
So, Dr. Ismael, for thermal software, right? What are the studies which were involved? Because it's for the complete human body, right? So, how did you approach your clinical studies for that?
So it's very interesting because, as you mentioned, I'm a sports scientist, but the Human started as a research group. Okay, it's not all just about me. It was in 2009, and since then we have published 60 articles approaching different lines, but most of them regarding not medical thermography, but in sports and health application. So actually, let me mention that we are very proud because we published our first Nature publication article last September. But regarding the clinical studies learnings, for me, obviously, there are 2 main things that I would like to mention, because we have explored a lot of different factors, from influence factors, protocols, very basic things regarding exercise and physiology. And then obviously what we are more interested, which is more regarding injury prevention and fatigue identification. For me, one thing which is very interesting is we are always frustrated by the big variability of the results among individuals. But although there is such a big variability, there are patterns that with the help of massive database and clinical studies could be identified using obviously statistic and artificial intelligence algorithms. And that's what we are starting to discover, from the most basic to the more advanced, as we saw in a lot of different presentations today. But the second point is the tough point regarding researchers and entrepreneurs, and is about transferring what we do in a laboratory to the reality. In our case, for example, let's think about NBA team or a Premier League team, right? And that's tough because obviously it's not always about having the perfect conditions, but how can we deliver enough good or quality systems, technology, knowing that the research quality is not going to be the best. And for us, our clinical studies are now focused on learning about injury prevention, fatigue identification, but also how can we provide good protocols without just being under the pressure of having the perfect condition as a laboratory. And this is our main learnings about how to implement and discover this technology in our sector.
Very interesting. Thank you. So I wanted to ask this question before clinical studies that because the data set is very limited for doing this training on your models for AI. So what are the challenges you faced? How do you use your data sets to train your AI models? So that's what is very interesting to know, that given that we are doing medical thermal imaging for medical usage and data set was very limited, how did you go about it? So anyone who wants to go ahead, maybe Ismael, you want to start?
Yeah, no worries. So our database, speaking about the thermal images, is now around 300,000 images that we have been collected so far over the last 14 years. The main challenges that, again, are regarding exactly what I was mentioning before. Analyzing people in a laboratory is quite good regarding the data collection conditions. But our main challenges now is, okay, is our system able to work the same way if the data collection is not perfect, if the acclimation time is not perfect, if we are missing very important information? Are our algorithms able to automatically detect false positives? For just, I give you an example. A football player puts some cream on the muscle before getting assessed with thermography. Is our algorithm able to distinguish between a natural asymmetry or an artificial asymmetry? This is the kind of challenges we are facing. And I don't mention about the ability of the technicians, wherever it's a physiotherapist, medical doctors, strength and conditioning coach, which is taking the picture, and some days they are taking the picture vertically, or they're very far away or closer, or just missing some parts. This is the most I would say unexpected challenges, because as researchers, we think everyone is going to be able to take good images in good conditions. Is not the point. So this is for us trying to scale up the use of thermography, understanding that not everyone is so sensitive and, let's say, researcher, and then how can we, although those circumstances, deliver good results with algorithms that are able to recognize those problems.
Professor Brioschi, you want to add to that?
Yeah, yes. In our case, we only use images in good conditions because we have 1 million image source from diverse continents, not only from Brazil, but from United States, Lebanon, Netherlands, Mexico, Korea. So we have a data diversity extends to the inclusion of a wide range of genotypics variation, because we believe that genotypics have very different patterns on the image. We can see difference, for example, people with different eyes, colors in the eyes have different images on the breast, on the hip, or on the legs. So ensuring a comprehensive representation of population and in diverse ethics. And I express significant concerns about relying on open source data sets that we have, for example, on the internet, because most of the time we don't know how these images were prepared or how long they were follow the protocols. So, for example, in the cancers, what kind of cancer? So in our data set, we separated if it's invasive ductal carcinoma, or if it's invasive lobular or medullary carcinoma, mucinous carcinoma, and we don't mix with, for example, ductal carcinoma in situ or lobular carcinoma in situ, because they are not cancer. So we don't mix this in data banks. And also we don't mix, for example, with breast implants patients, but we have these breast implants patients to compare the images. And also in our patients, we always looking for example, in breast cancer, if they have history as ovarian or colon cancer in the family. Again, trying to understand not only the image, but the genotypic variations behind or associated with these patients in the thermography.
Okay, that's interesting. Very nice data, like how we're using it. Dr. Geetha, how do you use, how do you train your AI models for the breast cancer detection in Niramai?
Yeah, so like I briefly mentioned in my previous answer, right, the first itself, we had to really try to get the images of good quality images and good quality labels by working with the hospitals. Like one of the previous speakers mentioned, taking any type of image of cancer patients or not requires ethics committee approval. So for each of these data set points, we had to go through ethics committee approval and to generate this 600,000 images right now we have, with most of them having the positives having a biopsy confirmed label and so on. So this was very, very mandatory, and on a hindsight, I think it was very important to get biopsy as the ground truth for this, because just looking at an image, 3 different thermographers may give 3 different answers, right? There's so much subjectivity and difficulty in interpreting this, especially the one-shot image. People are mostly used to doing sequence of thermal imaging and then sort of, comparing the two. So that's why, we were able to train the model with literally golden truth. So that was one of the main aspect of offline methods of finding the golden truth was most important. I know we're running out of time. Maybe one more question, I guess.
So last,
if I just quickly answer the same question again. So I think we are a little bit behind on our AI evolution from the other speakers here, but the way we've done this, we are currently, as I said, on our second training round of the shape detection. So for us, it's the main importance is we focus on the feet. On the DFU patients, we focus on the feet, and then the first generation of AI, we made people use a mask. So we thought that it would be the best way to ensure that everybody follows the same protocol by installing the mask on a phone app, and then when they see their feet, they must put them inside the mask, and they are completely visible on both sides. And this proved to be a real challenge because people who have diabetes and are often elderly, they have trouble with one foot being like this, and so it's not possible to have a mask that they just put their feet in. So we removed the mask, and in order to do that, we went to the local university hospital who's been using on their diabetic foot clinic. They've been using our system for 4 years, so they have thousands and thousands of images with the full story, just as you said. And we only just did this, and with this data set, we are training the AI, and we are aiming to remove the mask for the next gen, so that the only thing that people have to worry about is that both feet are completely visible on the screen, rather than having to force them into a different, like a fixed setup. And we think this will help them to still follow the protocol, but gives them more freedom and kind of not force their body into somewhere that it can't go. So, but yeah, so the images we've received that have got the full story, and they come from hospital, and they've been trained. They've been taken by trained professionals and following the correct protocols.
Thanks, interesting. Thank you. So one last, I know we are running out of time, but one last question, very simple, one-liner for everyone, because you guys are doing an amazing job. So what advice will you give for an aspiring entrepreneur who wants to enter in medical thermography and wants to use an AI? Dr. Geetha, I start with you first.
Sure. So I have 2 pieces of advice. One, don't underestimate the importance of clinical study. Okay, so it's absolutely important. You may get the first customer, but getting the second or 10th is impossible without a formal clinical study. Second advice, don't always keep the customer at the center, right? You are doing it for her, doing it for him, and that always has to be your focus of product development. Pass on.
Who wants to go next? Dr. Brioschi?
Sorry, I didn't understand this question. Sorry.
What's the question?
Yeah. So what advice will you give to an aspiring entrepreneur who wants to come into a field of medical thermology using AI? Because given you have done an amazing job in that. Yeah.
Sorry.
If I just jump in there in a minute. So our learnings is that when you start, just keep in mind that it's going to take a long time. So 5 years is surprisingly short time when you try to kind of disrupt the medical world. Keep that in mind, have a lot of money, have a good investor with really deep pockets, and somebody who shares the same passion with you, and always keep the patient in mind. I think that's kind of the key thing.
No, I understood. Sorry. We have this aspect, but we must not forget to think about regulatory collaboration with health institutions. So we must to be proactive, as Geetha are doing actually, trying to bring thermography to the public health, United Nations and the governments. We need to think to do free screening for diabetes, food, for breast cancer. Not we must be more transparent in our communication, to explain that we are here to help people, not to be competitor with mammography or ultrasound. Is not, but we must be to grow with quality management systems, introducing artificial intelligence, and we must be close to the networking and have mentorship that help us to be inserted in the society as not only an alternative, but with something that really makes difference. Not the difference between, oh, it's a false positive, false negative. No, difference because we can change the socioeconomic impact on our society. This is my advice.
Dr. Ismael?
Yeah, so understanding that the situation now is much better than 10, 15, 20 years ago regarding application of thermography, as with other approaches, people that might start right now might be seduced by, okay, this is something that is going to create a lot of money. And I don't deny that. So I really strongly believe that thermography, whatever is the application, and here we have Uni, Marcos, Geetha, with different applications, it's not about the potential, it's a reality. But again, what you mentioned, we have to keep always foot on research, clinical studies, and then the other foot on business. So it's like wearing the suit one day, wearing the glasses another day, and sometimes in the same day, both things, right? So with that, what I mean is if we are approaching thermography just as another business idea, potentially it is not your thing. And that's why I strongly recommend people to be, as Juni mentioned, passionate and also critic about thermography, because obviously we have seen that pure direct applications sometimes is not that easy, but with a big amount of patience, constancy, and very important, being also critic and researcher, makes a lot, and then the rest is a matter of time and success. So I would say that for anyone interested in this topic and technology.
Thank you, everyone. This is a good panel. Sorry we overshot for 3 minutes. Any questions you have for panelists, please write in the chat. And thank you everyone for joining this panel.
Thanks a lot. It was great meeting you all. Thank you, Himanshu. Excellent.
It was a pleasure. Thank you, everyone.
Thank you.
Bye-bye.
Bye. Bye.
That's a wonderful discussion. And moving on to the next one, we have a data challenge session, and it is chaired by Professor Alejandro M. F. Frange.
Super, thanks. Thanks a lot, Siva.
Yeah.
So we have basically 2 papers that will be presented, who have contributed to the challenge, and then we'll try to use a few minutes to sort of take opinions from everyone in terms of how we may take these challenges forward for future editions of the workshop. So the first presentation is by, I hope I pronounce it well, Ronak Teja from Niramai Health Analytics, and is entitled 3D BreastNet, a self-supervised deep learning network for reconstruction of 3D breast surface from 2D thermal images. And I hope the speakers will do that, but otherwise it would be great if you could make sure that you summarize a bit the aim of the challenge and the data sets as well as part of the presentation, if possible.
Yes. Hi. My name is Ronak Teja. I am working at Niramai under the guidance of Dr. Siva Teja and Dr. Geetha Manjunath. So this data challenge is basically where we have the 2D thermal images, and challenge is to construct the 3D breast surface or reconstructing the 3D surfaces, which can aid in visualization of entire region, which can aid in doing more precise diagnosis use cases. I can ask Siva if you want to add on the challenges. What does this challenge represent?
Yeah. So I think Ronak, you summarized well. So just to the audience, so this data challenge is about how we can reconstruct 3D breast surface from 2D thermal images without having any kind of ground truth. Because unfortunately, there are no labeled data sets where we have 2D images and the corresponding 3D image. So what we thought is that, can we have a data challenge which can come up with techniques that don't use any kind of labeled data set? And the advantage being that it can be used for breast augmentation, it can be used for visualization, so that the doctor doesn't have to correlate between the views. They can see one single view and then get the structural information of the tumor. They can assess physical asymmetry. And also they can assess whether there is a lump or any kind of physical deformation that they can see as well. So continue, Ronak, with the presentation.
Yeah, thank you. So with our intern Arka Prabha from Jadhav University and Dr. Siva Teja and Geetha Manjunath, we have worked on this problem and come up with one of the approach, which is self-supervised deep learning approach, which is called as 3D BreastNet for constructing the 3D breast surface from 2D thermal images. We will go over the problem statement and corresponding challenges with it, and the closest literature which is close to this particular solution, and how we approach, or what is our proposed approach to use the solution, followed with the results and the conclusion. So we all know, or several studies have demonstrated the effectiveness of thermal imaging in detecting the breast cancers. So the subtle temperature variations and asymmetries in the breast tissues have aided in early identification of these abnormalities. Currently, as a protocol, mostly for breast imaging, 2D thermal images are captured from 5 different view angles, namely like frontal, left lateral, left oblique, right lateral, right oblique, which are at plus minus 45 degree, plus minus 90 degree, and 0 degree temperatures. Now, while this images provides valuable information, it has limitation in representing the complete breast surface and spatial characteristics. A 3D model or a 3D voxel kind of images or 3D volume can help in visualizing the complete breast surface and model more precisely these abnormalities. However, there are no direct 3D data available because one is the cost of the 3D cameras. On contrary, 2D thermal images are available because of the cost effectiveness of 2D thermal images. So there is a need to bridge a gap between this 2D thermal images that we have and the visualization that can be created with a 3D model. And that's why we are, our aim of this project is to develop such algorithm without any 3D supervision, only using these 5 different view angles. So what are the challenges? The one challenge is we do not have any 3D ground truth supervision. Second, the number of views are limited in order to reconstruct entirely the 3D surface construction. And also the view angle. We have a standard view angle plus minus 45 degree or plus minus 90 degree, but they may have an offset of, plus minus 10 degree. So how do we overcome this challenge? And one of the approaches that we found out to be very close to this problem is perspective transformer net. As you can see in the image, the 3D object is there and the camera captures the images from various view angles. So these images are good enough to capture, the kind of the entire breast surface. That is a data set that is available. So the approach talks here that given an input image at particular view angle, a deep learning model is used to create a volume V, which would be initially a noisy version, but perspective transformation, or basically we can say projection, is taken of the 3D volume and a 2D silhouette is obtained. Now this 2D silhouette is compared with the input image silhouette and the difference is identified. This difference is then back propagated in order to improve the volume V which is generated. So entire back propagation happens such that a network learns to construct a 3D volume and construct the projection output which is similar to the input image. So in this fashion, when we have multiple view angles and it is being trained over various iterations and various epochs, the deep learning models learns to construct a volume only with respect to these images itself. So using this idea, what we have tried is instead of sending only one image, we basically give all the 5 images together as an input and do foreground segmentation. Since we want to send silhouette as an information, foreground segmentation, after sending it to foreground segmentation, we send it to an encoder-decoder architecture, which converts this 2D thermal images into a 3D volume, followed by a transformation in order to generate a 2D views, which involves rotation and rendering to obtain an object silhouettes, and it is being compared with the input silhouette and the loss is propagated in order to train this network. Once the training is completed, we overlay the generated 3D volume with the input temperature so that we get an output which is having a temperature information overlaid on top of it, which helps clinician to visualize the breast surfaces. So one of the important component is 3D silhouette generator, which is nothing but an encoder-decoder architecture. It is with the encoder downsampling the input images to the lower input dimension to get the latent representation, and reconstruction happens from latent representation to the upsampling. The another important piece here is a 2D view generator where we have the volume V which is generated and we want to take the projection. So an angle would be provided, for example, 0 degree, which is the frontal view, or 45 degree. So this angle is being provided, but then how do we take the 2D projection? So it is being done using a transformation TR, where TR represent a sequential rotation of the volume followed by the projection. So we use a rotation matrix in order to rotate the 3D volume. Once the 3D volume is being rotated to the angle which we need, we basically project it. The 3-dimensional input is being pushed onto a 2-dimensional data using a rendering transformation, which is nothing but an exponential decay over the channel axis. similar to the principle of the light, which keeps on degrading. So then we obtain a 2D thermal image here, and then we obtain the silhouette. So this is how we obtain the 2D view images. Once this 2D view image is obtained to us, the loss is being computed. So what is the idea that we tried here is, for example, if the view is frontal, I equal to 3, the view is frontal, which is nothing but the view is captured at 0 degree. So we have considered an offset of minus 22.5 to 22.5 that whatever, if we rotate the volume between minus 22.5 to 22.5, whatever silhouette we obtain, we compare it with the frontal ground truth silhouette itself. The reason is that we want to eliminate the need for precise view information, so which will help in tackling the view errors. So with respect to that, for every view that we have considered a range of offset angles, which is randomly being chosen while training the model. And this random angles helps us to eliminate the need for this precise view information. So once the loss is being used for training the models, the another important piece is overlay. So one reason why we do not pass the temperature information while training the model is because the temperature values cannot be perturbed. Deep learning model, there are chances that we may perturb the temperature information. That's why temperature information are being overlaid after the model is being trained here. In order to overlay the temperature values, what we do is we rotate the 3D volume, generated 3D volume, and get the projection and compare it with whatever input ground truth view angles which we have. From there, we try to estimate where maximum dice score we are obtaining, and that particular view at that particular angle is being overlaid on the 3D volume. So that is the basic principle we have used for the overlaying. As a training and for data set, we have around 2000 plus participants, which were used in collaboration with multiple hospital and diagnostic centers. We had 5 views, which are at minus 90 degree, minus 45, 0, plus 45, plus 90. These all images were captured using EFLAR E75 camera, which has sensitivity of 50 millikelvin. Resolution was 320-40. In camera lens, full view was 24 degree, 18 degree. The entire dataset was divided into training, validation, and independent test set. 200 patients were used for validation and independent test sets. The others were used for training purposes. So this is the results which we obtained, where these 5 views were given as an input, and we generated a silhouette, and then an overlay of temperature is being done on top of it. This is being, I'm showing for the 3 different input subjects. Also, we tried to check the accuracy with respect to, we basically came up with accuracies, dice index or Jacquard index, and Hausdorff distance, where input images which were captured at 0 degree plus minus 45 degree plus minus 90 degree, they have been compared with the generated 3D silhouette at this similar standard view angle, and what is the score that we are obtaining. So what we see is for the frontal view itself, like 0.983, like around 2% of error, not more than that. Similarly for other views as well. So which kind of says that the output that is coming is in line with the standard views which are present. So our proposed approach solves this issue and generates 3D breast surfaces without any need of explicit view angle and actual 3D ground truth. And dice loss of 5% on test and validation data set shows the ability of this proposed 3D breast net in generating the 3D structure volume close to 2 3D volumes. So yeah, thank you. I would like to have if there are any questions.
Thanks so much, Ronak, for your presentation. So I'll kick off with a question while hopefully we get some others from the audience. It wasn't very clear to me, Ronak, what was the fundamental assumption you're making when you do the reconstruction from these images. So if I understand correctly, you're assuming this is a projection operation, right?
Yeah, correct.
And to what extent you can actually make that assumption in the case of thermography, because this applies to this would apply well for X-ray. But are you trying to somehow get an information from? Yeah, I think I'm a bit confused between how you try to unravel the 3D nature plus the fact that it's only a superficial 3D, right? So you're trying to put that into a 3D surface. And then how that affects to the quantity that you measure in 2D, which seems to be an integral of some sort, right?
Yeah. So first, the thing is that the 3D object which we are capturing, we basically have 5 different view angles. So it entirely covers the surface, like those input temperature values that we have. It's enough to see the temperature value at each region. Now, since we have this information, what we are trying to do is overlay these images in order to get a complete 3D surface view together. And to do this, what we try to do, as you mentioned, right, volume is constructed, which would be noisy, but we take a projection. Now, for example, if the camera image is taken at 0 degree and the volume is generated, we take the projection at 0 degree, and whatever silhouette we are getting, we are trying to compare it with the input silhouette itself. So generated volume is 1 and actual image that is captured from the FLIR is 1. So the projection which is coming from the generated volume is being compared with the actual image, and they are tried to be made as close as possible. I guess that is one way of how we are trying to do this process without any 3D supervision. Yeah, I hope is whether that answers the.
Yeah, I think the summary would be that you are not looking at tomographic, you're trying to get purely the surface, and also that you will have always direct line of sight from at least one of the cameras, right?
Yeah, correct. Yeah.
Okay.
So yeah, the thermal data, which is the temperature values, they are being overlaid later on because we don't want to perturb it. So, and that has also been taken care that there is no perturbation. Yeah.
Super. Any other question from anyone in the audience? I cannot see all of you, so if you could just unmute and jump on it if you want to ask.
No, thank you. If anyone has question, can connect me on the chats.
Yeah, super. So we'll move on to the next talk, and perhaps there are some. I'll open again for questions at the end if anybody has before we move to the roundtable. So the next paper is modeling the 3D breast surface using thermography by Gleison Costa from the Federal University of Maranhão.
Okay, can you hear me?
Yeah, very good.
All right. So good morning, everyone. I'll be presenting to you this project named Modeling the 3D Breast Surface Using Thermography, done by me, Eudoxia, Thiago, and Aura Consi. For a brief introduction, breast cancer is the most common type of cancer among women in Brazil. And there is expectation in 2040 to have an increase in the number of the cases to over 3 million. The generation of 3D models provides a satisfactory result for breast reconstruction after a radical mastectomy, as also it helps the exams when you have a full vision of the model using the projection of the images of the thermography exams. So this project, it aims to develop a methodology to create a 3D breast models using those thermographic images automatically. The methodology of this work is divided in 2 big areas. The image processing, that's responsible to obtain the geometry aspects of the body, the shape, the curves, the key points, and computer graphics that it's responsible to positioning the curves, positioning the key points at the same coordinate system to create the volume, the geometry models. The image that we used here are acquired from the Visual Lab website, where we used 104 exams, where each exam has 5 images. Each image has a specific orientation based on the bar in front of the camera. So we have the frontal, it's at 0 degrees, oblique right, 45 degrees, total right, 90 degrees, oblique left, and total left. All of them based on the rotation of the bar in front of the camera. So going through the image processing area, we have 5 steps here, where we start with the pre-processing, where we convert the exam files to image, and then we rescale them to pass through a UNet model. We use the UNet for automatic segmentation. It works as a decode and a encode architecture, and it gives us the segmentation of the breast. So the breast is our region of interest. So as long as we have those images, we pass to some refinements, that is to only take the biggest area. So the segmentation on UNet can give us some small regions on the image, and the refinement, it's responsible to get the biggest one. With the region of interest, or ROI, we start to retrieve the shape of the breasts. So we are looking for the left, the right, and the bottom lines of the body. So left, right, and the bottom, right, and the bottom of each one of the images. And we use these curves to get the key points. Our key points are the position of each breast. So the right breast, the left breast, and the point in the middle of the 2 breasts. So the result of this process is getting the curves and get the key points. We use those curves and key points to start our computer graphics process, where we start to make the geometric transformation, where we rotate the image based on the degrees of that image. So for example, this one is 45 degrees. We rotate this image in 45 degrees over its key point. So that's why it's necessary to have the key points. The curves are rotated, and then we adjust every curve to a B-spline process, where we can have a specific number, an equal specific number of points. Once we have all the curves, once we get all the curves rotated and positioned over its key points, we can generate auxiliary curves. So if I have on the left breast a curve here, I can mirror this curve to other side to have auxiliary one. So in the final, I can have nine curves, and those 9 curves are used to create a surface. The surface is done by the NURB surface, where I can use in this the 9 curves as control points. I can have the surface, and this surface is used as long with the image of the exam as the texture map, and I can have the final result as you can see here on this video. So in this video, I rotate the model that was generated by this methodology. So the results that we have here were done by using a survey that was passed to 15 persons. Among them are medical expertise, academics, and modelers, and they were answer about the model, how we gave us the images and the models, and they were discussing, they were answering about how well the model was done. So as you can see here, each column here is one model, and we have here the positive, the neutral, and the negative response of them. So as long as you can see here, 7 of 10 models were analyzed as well constructed. So we have a low value here in negative if you consider only this. So as conclusion, we could make a model automatically based on the images, but we don't have right now the ground truth, so we have to construct the ground truth to take a new scores. If you want to see more about this project, this work, and the videos that was done of each model, you can access by this QR code. And thanks for your attention. If you have any questions, I'm happy to answer.
Super, very good, Gleison. Thanks so much for your talk. Is there any questions from the audience?
Hi, yeah, I just had a question.
Super.
Yeah, so how is the quality of the reconstruction measured as one? And the other one, I just want to know if you compared it with the actual 3D camera image, if that's possible.
Sorry, can you say again?
Yeah, so how is the quality of the reconstruction measured? And were you able to compare the 3D reconstruction with image that was captured from a 3D camera?
In the moment of the project, we didn't have access to a 3D camera, so we only used the image, and the evaluation of the final work was done by a survey where the doctors and academics analyzed the video and the images that we passed from the exams. So it was a leakage scale analysis by then. So we are starting now to make evaluation using a 3D camera, but until this point, we don't have analysis using a 3D camera.
Yeah, thank you.
So one
Thanks
more
so
question.
much. Any other question?
Yeah, one more question. So on the last to last slide, metrics like positive, neutrino, and negative was there, right? So what does that represent actually? I just missed out.
This answer here are based on the answer of each one. We make questions about how they consider the accuracy of the model. If they can't identify a model there, it was about quality of the models. So if you, in this QR code, there are the questions that we have done to them, and there are about 80 questions for each model. So with those questions, using the Likert scale, we made some statistics using those responses. So I didn't bring here the answers that we have done, but you can access here on the QR code. But all other numbers here are based on the answers in a Likert scale.
Got it. Okay.
So this is essentially qualitative.
Yeah. It's a quality.
This expert's opinion compare.
Yeah.
And one question to both yourself and Ronak as well is, guys, how important is, I suspect that you have a largest error in the portion that is in between and lower in the breast, because that's where you have the most potential occlusions and you have less views, right? How important are those portions in regards to diagnosis? Is that something that, yeah, well, first, is the error larger there indeed, as I assume? And if so, is that something that you say, well, actually, yes, that's the case, but you don't care because you don't tend to have a lot of problems in those areas? Or we should be looking into that?
You are talking about this inframammary region here?
Yes. And also, I would say, in the portion of the breast that is effectively touching the torso, because it's sort of hanging over the torso fundamentally.
Yeah, at this point here, I don't see all the models that I have created. I haven't seen a large difference on the final result at this point right here. It's more about a more aesthetics information. So we know here that the breast is not this curve right here; it's more pointed. So for the exam, I don't see any more information that I can retrieve from this point, but it's more about the model, the aesthetics
Ronak,
of the...
Yeah, thanks a lot. And Ronak, do you want to comment something about that, about your experience on the other paper you presented before?
Yeah, so I guess it's very important analysis to look into those regions, and we have actually looked into it, and what we found out is the oblique and the lateral view gives the most information in that region. Like for example, the slagginess, the shape, the size, and we found that those contribute majorly, and that's why like we can have some custom laws with respect to the views also, so that we can construct those regions very well. What we found from our current algorithm, it is doing the job very well, but still there is still a need of more metrics to to look into issues more precisely. Also, we plan that currently we use the entire breast surface as an input to images. Probably we can also try to eliminate the inframammary region and try to give the input as it is and see how the bottom of the breast or the those regions can be evaluated more critically there. So that could be one potential thing we can try to do and see what's the difference.
Super. Okay, so I think if there is no final question, I'm giving a few seconds in case someone wants to ask anything to any of the two speakers. Okay, if not, what I'd like to ask you is if you could unshare your screen, Gleison, and also to make it a bit more personal, I'd like to ask all of you to unmute, sorry, to put on your video, basically.
Okay.
So we can have a bit more of a interaction between all of us. Yeah, so what I like to do now is, and I'm gonna just throw 4 ideas to kick off, but I'm really keen to, and I'm sure Siva will be very keen to hear your views for next edition as well. So it's about what are the areas that we could improve on these challenges moving forward. And I'm going to give you 4 points that I thought, partly as we were discussing today in previous sessions and partly preparing for this event. So one is, I think what we have an obvious thing, which is we probably need to look at ways to engage more people in these competitions, because I think it's very helpful to hear from, say, Ronak and from Gleason about the work they've done and their experience. And the more people we have who have gone through a particular case study and report on that, the more we will learn. So the broader question is, how can we expand on the audience and the participation? And I'd like to hear your views about that. And then the second question is about what should we focus on in future editions of the challenge. And I mentioned that I had 4 points, but actually it's only 2. It is 2, but I have 2 ideas for the second one about, and one is actually stimulated by Catherine's presentation before on, should we be looking at using synthetic data to, or about developing the methods for synthesis where we compare them in terms of realism. So it could be either angle, but it's around synthetic data. The second one is, I titled this thermographic image analysis in the wild. And if you are from the computer vision community, you know what they mean in computer vision by in the wild is, uncontrolled. And this was sort of inspired, I think, by a comment by Ismael, where he was saying, it's good to develop a method for one particular setup with, expert people collecting it, but the reality is there's a huge variability there. So the idea there it would be more about, can we explore variability? I think the challenge we did this year on 3D is still a very relevant one. And, my suggestion is perhaps we should try to improve on the data we make available to people and try to provide a reference data set, but still run it next year. And maybe, we don't need a single challenge, but have more than one sort of categories of competitions. And that might be a way indirectly to expand on the audience and participation. If we do the challenges super specifically, the problem is, if they're very, very specific, the problem is you narrow down a lot the amount of people who will be interested in. Anyway, just a bunch of thoughts I throw there, but I'd like to open now the floor for ideas and for comments from everyone else.
I think it's a very good point, Professor Alex, about the data synthesis. So given that I think many startups or also many researchers are struggling to get hands-on experience with the actual data sets, it would be good to see, can we come up with synthetic data? Because there is always restriction about data sharing, especially we are dealing with patient data. But if you can synthesize these synthetic models, and if we can open source it, that would help significantly for other researchers in other countries. They can take this model, and then based on the synthetic data they get, they can either retrain the model, they can see how they can use it in their training. I think that's a very interesting problem I think you brought up today. And the second aspect also is having multiple challenges. I think it will definitely accept more acceptance in the researchers. And the second challenge also is very apt, given that many startups are working on whole body thermal imaging, like ThermoHuman we have seen, and Niramai we have seen, and even Professor Brioschi also was talking about multiple imaging. And as you said, can we just give a thermal image and then ask it to identify where the abnormality is without even telling what image it is? I think those two are very good, interesting topics that you brought.
One thing, Siva, that as you were speaking came to my mind is there are 2 ways of doing synthetic images, right? So one is in the way that Catherine was summarizing, which is basically by AI synthesis. I would call it more phenomenological synthesis, because you don't model the mechanism of generation, you just generate something that is a plausible image. But then another thing that we do in other imaging modalities, and I think it should be fairly simple to do it in thermography, is you can develop finite element models for it as well. Yes. And there are very good models of the breast that other people have developed for for other purposes. And I'm just wondering whether we need to also look into that, is so that you have full control on the lesion size, the thermal properties, and then you generate a large data set that then is used for training AI algorithms. Is
Right.
anybody here that has experience on doing that from the audience?
Professor Brioschi, you want to speak?
I like to comment something that I learned. That is, we know that in engineering have a lot of solutions, mathematical solutions, and medical doctors have a lot of problems, medical problems. So I think that we need to join the solutions with the problems, and for the next challenges, we must to ask for the doctors what are the problems that they want they need to be solved. For example, there's when you see a suspicion lesions on a breast image in infrared, could be interesting to understand the size, the depth of this lesion. So mathematics involved in this kind of problem could be more interesting than the 3D, for example, in my opinion. Sorry, it's just my opinion, because most of times we don't have idea how big is the lesion we are talking in that breast image, or is a in situ cancer, or is a big one, or there's no relationship. So I think this could be something very interesting, a good challenge for the next edition. And just my suggestion. Thank you.
That's a very it's a very good point, Marcus. And one of the things I'm going to do to perhaps feed a bit into that challenge that you put us is this link I'm putting now in the chat from the. So I'm not going to give you necessarily a solution to that point, but a pathway to think about a solution. So the American College of Radiology developed in the US, well, they have something called a Data Science Institute, which is essentially trying to do AI-enabled radiology. And they developed one thing that I think is quite interesting. There is a list of AI-related use cases, which are all defined by radiologists and prioritized by radiologists and specified by radiologists. I'm wondering whether we have a similar community, clinical community around thermography that we could work during this coming year in sort of establishing a long list of possible use cases. Because, Marcos, I assume you're a clinician from what I remember from last year and this year as well. And engineers are good when we give them a target, and I'm an engineer as well. So if we define a set of use cases, we are telling them this is what we want you to hit with your tools, right? Well, if we give them data but with no target, no use case, then essentially they will come up with any algorithm that sort of uses the data, which is half useful but not necessarily fully useful. So maybe this could be a way to progress on this item. And I just put in the link, there are examples, and you will see that they divided them by different application domains, so like abdominal, neuro, and so on. And then for each of them, if you look at each of the use cases, you will see that they define, what is the value proposition, the narrative of a particular case study, what are the considerations that need to be taken into account, and a number of technical specifications. So we could use potentially the same templates that they develop, maybe review it first, just in case there are some things that don't apply to us. But then once we have that, sort of do a call for those use cases, if we have a few clinical champions that help us with that.
I think very interesting perspective, Professor Alex. I think it's definitely required, having a data bank kind of thing, having each data set and corresponding targets would really help, basically in creating more awareness also, because many people know thermal imaging, but they will not know for what it will be applied and what kind of data set it is relevant. I think what you suggested would really help in that. Any comments, Professor Oraconsi or Dr. Ismail from Thermo Human? And Professor Or, I think you have open sourced many data sets like from Visual Lab. Do you want to comment anything?
Okay, I think probably people are getting a bit tired of the fact that it has been a long session, and I reckon that
in fact, here in Brazil, we were very beginning of the day yet.
I know.
But I have to congratulate you about the idea of this workshop. I think that is really the most important thing is the sensation of a community working the same subject. I think that is very relevant to show the importance of the team, the importance of the idea, and the importance of the thermal image in health, in improving in some kind the diagnosis of any kind of disease. I think that is the most important, in fact. Thank you for Siva. Thank you for everybody.
Thank you, Professor.
Super. I think this is a good point, Siva, to hand over back to you.
Yes, thank you.
Closing.
So I will make it quicker, given that I think it's very late in some countries and very early in some countries. I'll just finish in like 4 minutes.
Okay.
Yes, finally we reached the end of the session. Hope you enjoyed and learned from the talks and panel discussions which we have witnessed today. This wouldn't have been possible without the support from various people, starting from the organizing committee, who are responsible behind this idea of having a dedicated forum to discuss about the clinical use cases of AIIMA. It all started as a discussion among us, like Professor Alex, Dr. Geetha, and Dr. Robert Scott. And then we soon realized we have to start a full-fledged workshop. And then last year, we applied MICCAI. We selected MICCAI because MICCAI is one of the top-tier conference. And since then, the organizing committee is behind, making it successful. I would like to also thank our new members of the program committee, Professor Gabriel Brioschi and Professor NG, who bring their valuable and immense expertise in terms of both AI as well as a clinical perspective of AIIMA. I would like to thank external reviewers who reviewed the manuscripts that were submitted. We have a significant number of submissions, and we had to submit all the reviews like within 1 or 2 weeks. And the reviewers did a tremendous job in submitting. Can others mute? And now everything in timeline. I would like to thank our main sponsor, Niramai, who are mainly responsible for getting social media attractions and also organizing panel discussions that we have seen today. I would like to thank MICCAI for continued support and selecting AIIMA as one of their satellite events, event 2023. I would like to thank the Springer LNCS publisher for publishing the AIIMA 2023 proceedings. I'm happy to say that the proceedings of 2023 are published at this link, and we are providing a free access to everyone till November 2nd, 2023. And thanks to all authors and speakers, despite late and early in some of the time zones, being online and participating in the discussions. And thanks to all authors who have submitted the manuscript, and we hope to see more number of manuscripts in the next session. Thank you all for attending the conference. Any kind of feedback, you can reach out to us to aima.miccai@gmail.com. See you all next year. Thank you all. Okay, thank you all for joining.